Morning, everybody. If I could just have your attention before we start the formal part of the meeting. I've just had a discussion outside of this meeting with Mr James Wood, who represents the PPG for Parkview service users. And before we start the informal part of the meeting, I'm inviting James just to come to the front. If you want to sit down, James.
No, Jimmy.
Jimmy. Is it Jimmy? To come to the table, because please. And Jimmy would like to read a statement to us. We'll listen to the statement, Jimmy, absolutely, and then in due course, if we need to respond, we won't respond today. We'll respond in due course, if that's okay.
Raj, first of all, thank you for allowing us to speak for a few minutes relative to the campaign we've had, albeit unsuccessful, over the last 4.5 months for the saviour or trying to save Parkview Medical Centre. I had a brief discussion with Raj down below, and thankfully he's allowed us to say a few words. You've got important business here today, so I won't take up too much of your time. On the occasions we've been here at Warrington and Runcorn, I've heard from the people who represent the various bodies, from the chemist to the dentistry, to say how difficult a job you people have here to try and keep it going on the 75th anniversary of the NHS, a marvellous and wonderful institution. And we've had some marvellous people campaigning to help and support, from the Metro Mayor, Steve Rotherham, to the local MPs, Ian Byrne, Dan Carden and Paula Barker, and also the leader of the City Council, Liam Robinson, who ironically, Parkview Medical Centre is in his ward. But sadly it was to no avail. Just a little bit of a brief background on Cheshire. It's a very, very deprived area, Cheshire. Very deprived indeed. We lost a bank a number of years ago, which was part of the community. We've lost a chemist in Cheshire, part of the community. We lost a police station in Cheshire, part of the community. So you can believe and hear what you see around Cheshire. And all of a sudden, over the last number of years, through no fault of their own, we've had a big increase in the migrants coming into our community. HMOs, where they're bringing in many, many flats, where they've changed them from big houses into flats. So we've had an input. And it's been a very, very difficult time for Cheshire. And now we've had the closure of our wonderful surgery. With just on 3,000 patients being dispersed. And thanks for what you've done to disperse them, and you've helped in trying to get them to where they can go. But you know and I know the difficulty you have of getting an appointment. And where my wife and I have been sent to, Green Lane, I believe there's over 900 patients being put in Green Lane. It's an area for me, by the way, my lovely wife. But it's how they're going to cope with them extra 900 patients. It's going to be very, very difficult indeed. But hopefully they'll get through that for the sake of the patients. The PPG, under the terms of reference, the doctors who are in charge at this moment in time, Dr. Jude, Dr. Abdi and Dr. Karam, they failed in a duty of care. Our PPG have asked on numerous occasions to speak to Dr. Jude, the main provider, just ignored us. Over 40 phone calls I've put in. Carol has helped me. Is Carol here? Carol Hill. Carol has helped to try and help us to get Dr. Jude to come to the table and discuss what's going to happen with the dispersal and what's going to take place. Well, on deaf ears, Carol. And she has tried on a number of occasions to get him to ring me. One occasion he rung me, he said, I'll be back tomorrow. That tomorrow was 3 months ago. That can't be right, that. Professional people saying to us people, and, you know, being economical with the truth, it can't be right, that, for Dr. Jude to do that, and Dr. Abdi. But however we are where we are, you've closed us down against the wishes of the community, against the wishes of the patients, but we are where we are. The old saying, isn't it? The operation was a success, but the patient died. So thanks for your for listening to us, and we will move on. And God blimey, you know, Green Lane, they're going to get the next PPG, so you haven't heard the last of us. Hasta la vista. Thank you.
Jim, if I could just say a few words. Firstly, thank you for what you've said. You've, it's heartfelt, it's your community, and you're speaking in such a dignified way about something that's really, really important to your community. We've heard the messages, and we'll cogitate, won't we? And if we think there's further things that we can come out and speak to you about, we will do that. But thank you for the way that yourself and the PPG have conducted yourselves on this really difficult matter.
Thank you, Ross, and thank you all for listening. Oh, by the way, here's the petition here.
We will receive that petition, thank you.
Well done.
Thank you. Let's welcome you to July's Integrated Care Board public meeting. This is a meeting in public, and again, I always welcome members of the public to hear what we've got to say. If we could go around, I'm Raj Jain, Chair of the board. If I can go around the table and ask people to introduce themselves. Ian? Thanks, Jimmy. Thank you.
Good morning, Ian Ashworth, Director of Population Health.
Good morning, Fiona Lemons, Associate Medical Director.
Steve Brimmer, Chief Executive of Warrington Borough Council, Parliament Member.
Good morning, Chris.
Morning, Hilary Garrett, Non-Executive Director.
Good morning, Anthony Middleton, Director of Performance and Planning.
Hello, it's Sarah Thwaites, Liverpool Health Watch, on behalf of the 9 local health watches.
Hello everybody, Councillor Paul Cummins, Cabinet Member Adult Social Care for Sefton Council and Partner Member Local Government for the ICB.
Good morning, I'm Claire Watson, I'm the Assistant Chief Executive.
Good morning, I'm Louise Merter, I'm here to take minutes today.
Graham Irwin, Chief Executive.
Hi, Claire Wilson, I'm the Finance Director for the ICB.
Good morning, Mark Bakewell, Interim Place Director for Liverpool.
Hello, I'm Chris Douglas, Director of Nursing and Care.
Good morning, I'm Rowan Pritchard-Jones. I'm the Medical Director for Cheshire and Merseyside.
Good morning, I'm Neil Large, Non-Executive Director.
Good morning, I'm John Llewellyn, Chief Digital and Information Officer for the ICB.
Morning, I'm Anne Moore, I'm a Partner Member and I'm Chief Executive of Mersey and West Lancashire Teaching Hospitals.
Good morning everybody, my name's Adam Irvin, I'm a Partner Member from Primary Care.
I'm Naomi Rankin, I'm a GP and also a Partner Member for Primary Care.
Tony Foy, Non-Exec Director.
Thank you. We've had, we've actually got 3 apologies: Joe Rafferty, Erica Morris and Warren, who unfortunately has had a car accident on the way here, so hopefully he's fine. Any declarations of interest that are not, you've not declared that are relevant to the agenda? And if I can formally record the fact that there is now an updated paper of everybody, of all board members' declarations of interest. That'll be on the website, I am sure. I think it's nearly complete. For those of you who haven't completed it on time, please do complete it. I think there's only 2 people, but I won't name names. Okay, thank you. If we can go to the minutes of the previous meeting, can I take any matters arising or accuracies that are not on the agenda? None. Can I seek your approval of those minutes as being a true and accurate record of the meeting? Somebody would nod, that would be really good. Thank you. Thank you. If we can go to the board action log. It's here for noting. Are there any updates since the papers were produced? Claire?
Yes, so I can close 22, 28, 22, 36, 22, 37, 22, 43, I think, and 22, 49. And I've emailed Matthew for that, so I can close those.
Thanks for that, Claire. Yeah, it's good to get some of these ongoing ones closed, especially the ones that have been long-standing. Are those the only updates? John?
Yes, 22, 42 we can close as well. That's been...
Thank you. Chris, and then Fiona.
Thank you, Chair. 2246, it says that we'll bring that back on a quarterly basis. We agreed that. Sorry. Apologies. Is that clearer? Okay, thank you. So on item 2246, we said we'd bring a quarterly update. We agreed that in May, but it's down as a bringing back in June. That obviously should be October.
Thanks, Chris. Fiona?
Thanks, Chair. Item 2230 about the learning event following the end of industrial action. 2 points. 1, we did a learning event on the 20th of June, and 2, we haven't come to the end of industrial action, sadly, but that's complete as well.
Thank you, Fiona. So if people are happy to move on with those updates, thank you. There's the board decision log. Again, for noting, unless there are any corrections. Happy to accept that. Thank you. Chair's announcements. Move to item. One announcement from me. It's double check my notes 1 second. It's just, firstly, there's a couple of announcements. Firstly, it's just a reminder to the board and members of the public. At our last public board meeting, we discussed the importance of making sure the board had time to focus in on really important issues in terms of how it can do its work, where there needs to be that in-depth stuff that happens, and then enable the public board to be really, really focused on matters that are relevant to the public. You can see the agendas of the last 12 months, I think, which an awful lot of it has been around the mechanics and the governance of the meetings. And as we move forward, we think that a lot of that's been changed. So, at the last board, we agreed that we would move to a situation where we would have a public board every other month. I'm hoping that's a really good thing that happens, and I'm hoping our colleagues and members of the public will actually see agenda items in their fullest sense, so you can hear the in-depth stuff that's going on, as opposed to some of the mechanical stuff that has to happen in this board, in this current incarnation of the board. So we'll see that from September onwards. We'll review it as always to make sure it's working for everybody. We're also just launched a recruitment campaign for an additional non-executive director. Our non-executive directors have been carrying an awful lot of load, both in terms of establishment, but now in terms of understanding what we need going forward. And we're hoping to recruit to that 5th position by October, I think, Matthew, is the ambition. and the adverts are out. And lastly, I just wanted to make a comment about the AGM, which will be in September. It will be at the Halliwell Jones Stadium, Warrington, and it will be the first AGM of the ICB. So I do hope all board members will be there. I do hope as many members of the public and staff can attend that AGM in September. So that's Chair's comment. If I could move to the Chief Executive's report.
Thank you. Thank you, Chair. As you know, I use this report to highlight a number of matters that perhaps wouldn't make it onto the agenda at this point in time in other ways. I'm not going to talk to all of them, although myself and the team would be happy to take questions on any of them. But there were just three things that I wanted to highlight today. First is the ongoing industrial action. You've heard me say this before, but to all of the people who are involved in managing the industrial action, the people who keep our services safe, the members of staff in all of the back offices, in all of the hospitals that have to cancel appointments, rebook appointments, reschedule theatre times, this is something that's having an enormous impact on the resilience of the NHS. But the fact that time and time again, staff are raising their game to cope with the consequences of industrial action is something that we should note, we should thank them for, and we should really understand the significance of it. Now, at no point in time have we ever criticised the right of our staff to take part in legitimate industrial action. And again, whilst you can see that the government have now settled pay arrangements with the majority of staff groups, the pay arrangements with our doctors still remain outstanding. And between writing these papers and coming here today, both our junior doctors, which is a really unfortunate naming convention, because they are the doctors that deliver the majority of frontline care in our hospitals. Those are doctors that in many cases are many years post their initial qualification and are very experienced, have announced another set of strikes, and our senior doctors have also announced days of industrial action. So it will keep having an impact on our services, and it will keep knocking us off course from those important things, particularly around elective recovery. And again, it's not just the number of planned operations that are cancelled, but it's those that have not been booked in the first place, because we have anticipated those days and the number of doctors that will not be in work. You've also seen this week the Society of Radiographers strike, and again, the impact that has in particularly complex cases. There's a number of instances of things like spinal surgery that can't go ahead unless there's a radiographer there in theatre to support the surgeon. So these aren't just minor procedures that are being cancelled. These are significant procedures. Now, again, luckily in the case of the spinal ones, the Walton Centre, everybody who was cancelled this week is being done this weekend. So again, you know, the Herculean efforts of the NHS to make sure this does not have an impact on people's chances of a speedy recovery. So I'll stop there and I'll move on to another area, which is something that is repeatedly coming to my attention, and in some regards maybe a phenomenon that we hadn't anticipated post-pandemic. So I wanted to draw to your attention that a national framework was published this year for what a good all-age autism pathway should look like. And that set out effectively some standards upon which we must complete an assessment for somebody to see whether they do have autism, and then standards for how long it should take us to get into treatment. But if I look at the services that have hitherto been in place, what we have found is post-pandemic those services have been overwhelmed by demand. And in the majority of our places, we are not getting anywhere close to delivering timely assessments for people. And as I said, in a number of our places, I find that the waiting time to assessment could be longer than a year. Now, that tells me that demand has gone up significantly. That also tells me that we haven't got the capacity right to meet that demand, but it also tells me that we haven't got the pathway right, because there are a number of processes that we could go through to make sure that the right people and the priority people are undergoing that assessment, and that we don't just tip everybody into the same waiting list for that process. So I'm sharing that with you today because I don't think it's our job always to bring good news to the meeting and the table, but to say this is something that we will have a major focus on. This is something that we will work through with each of our places, and we will look to put a plan in place as to how we can better match capacity to that demand, but also how we can make sure that we have appropriate care pathways in place. The final thing that I wanted to just highlight, and we've put here in the Chief Executive's report rather than a separate report, is the dental services update. As you know, we took on responsibility for the commissioning of dental services from NHS England, and this isn't a criticism of NHS England, but we know that across the country there are significant problems with people accessing an NHS dentist. We expect at some point in time the government to publish a dental recovery plan. A dental recovery plan that will address a range of issues, including the format and the nature of the contracts with the dentists themselves. And it's not in our gift to change those things, and that will be fundamental to the improvement in this area. But what is very clear to us is there are a number of things that are in our gift, and what this work sets out is, as part of the due diligence of taking on responsibility of this, we have already assessed what we think the likely outturn expenditure will be on the budget that we have inherited from NHS England. We have already forecast that it will significantly underspend, and that in itself is quite a complex process, because again, each dentist that has an NHS contract doesn't have to deliver that contract in even monthly portions, so we only know retrospectively on catch-up how much work has or hasn't been done. But we've reliably forecast that. We know that budget will underspend, and therefore our Primary Care Committee have discussed and have authorised the implementation a range of 8 projects to improve that access. So it's a kind of short-term stopgap to say we've inherited it, we know we can make it better, but actually there is more coming nationally around the dental contract, and there will be more that we can do when we've had a little bit longer to get our strategic planning heads on this. But I thought it was really important to share with you that baseline here today. I'm going to leave it there for today, Chair.
Thanks, Graham. Any questions or comments for Graham? Got Steve and Paul and Sarah.
So, Graham, on page 40, you mentioned the pressures on community and mental health, and I think we're all experiencing that in our local areas. I particularly wanted to raise in that.
Speak up, please.
Yeah, sorry, I will do. So, community mental health pressure, you mentioned in your report on page 40, Graham. So, in that context, just wanted to raise the issue of right care, right person. I think they'll be aware the Home Office and police constabularies, our 2 constabularies, Cheshire and Merseyside, are considering a withdrawal of certain support arrangements for individuals who have mental health issues and incidents. Certainly the police in pressure in Cheshire have spoken to us about it, and they're taking, I think, a realistic and phased approach to this, including agreeing they will not attend suicide events. Now, it's going to put pressure on all of us as a system, this, if the police are withdrawing, and I'm not quite certain where the resources in a coordinated way are going to come forward dealing with some of these issues that we'll present. So just ask that perhaps at the next meeting we have a report or a note on what our plans are to react to these changes that the police are introducing from actually next month. That's the situation for Cheshire.
Chair, so I have asked our place director for Wirral, a gentleman called Simon Banks, to lead on this for us across the patch. He actually attended the Strategic Police and Crime Commissioners Partnership meeting for the Merseyside area yesterday. He attended with colleagues from Merseycare, where they went through in some details the plans for how we're going to work on this together. He is also making arrangements to attend the Cheshire Police and Crime Commissioners meeting, but I don't have to hand the date of that. Now, we have had a range of investments, government-sponsored, to increase the mental health provision in these first contact areas, and I think I'm confident that we will work together with our partners well and have a good plan. But I think it is absolutely reasonable that we bring that back next time to assure the board.
Thanks, Graham. Paul?
Thanks, Raj. My question is on the same item, 2.6, and I support Steve's comments around work with the police. But month after month, we receive information that 100% occupancy of our mental health beds. And I've asked this before, I know, and I've been told that, no, we don't need any more mental health beds. I've asked, do we have an under-provision? And I'm told, no, it's about, as you indicate in your report, Graham, it's about shortage of supported housing and appropriate placements. Can I ask, have we got anybody working at a Cheshire and Merseyside level looking at working with the 9 places around provision on this? I think this is an ideal topic for the Health and Care Partnership to be taking up, as we've got the 9 local authorities present at that. But really, I think we need to get something moving on this and a priority, because this situation is causing absolute misery for so many people. And I speak to my social workers in Sefton, and they tell me the situations that are happening when people haven't got an access to a bed, having to wait days in absolute misery. And that's not right at this time. So please, can I ask, who is leading in this? Have we got any sort of an initiative on this? Or is someone asking the 9 local authority areas what they're doing in conjunction with the NHS to make a difference here and have some impact?
Graham?
Thank you for making the point. You know that the HCP is going to have a health and housing summit in the near future, and it is really important that we look across the whole spectrum in doing that. Now, we are working with the housing providers, and there is a balance here between how much of this is being dealt through place and how much of this is being dealt at a strategic level. So I will go away and look at that, and I will look at the effectiveness of our working relationships with our partners, and I won't wait till the next board meeting. I will do a note round to you to confirm the arrangements.
Thanks for that, Graham. I think what we want to see is some concrete plans in place to make a difference here and to impact on this figure, which has been going on for far too long now.
Thank you, Paul. Sarah?
Okay. Thanks for the report, Graham. There's lots of really useful information in there, and there's 2 points I'd like to pick up on. First, not surprisingly, is the dental one. Noting the parliamentary dental inquiry, which ourselves and many other health watches gave detailed submissions to, and agree completely that we do need a national dental recovery plan and made changes to the contract, which isn't working for patients or for dentists. But welcoming the local plan in the meantime, it's important that we use all the actions we can do in the moment, recognising how limited those are. because the stories that all of our health watchers are getting on a daily basis are of dental misery, to be honest. In Liverpool, most patients who need a dentist, there's only a tiny area of Liverpool where you'd be able to get a dentist because it's postcode specific for one dentist. So we get every day phone calls from people who have been distressed. It's been years for many of them since they've been able to access a dentist. So anything that we can do and anything our intelligence can feed into, speaking on behalf of the 9 Health Watches, we'd be very keen to be involved in that. And the other point is around the Give Digital a Go. It was something that we weren't aware of until we saw the papers. And it would be good to join up on communications, because putting something on the ICB website doesn't guarantee that communities see it, and tying it in more to what's going on in neighbourhoods would be useful. But also making sure that we always remember that while it's good to support everybody who can access online to do so, there's a lot of people in our communities who can't afford the digital. They've taken out their Wi-Fi, they can't afford to top up their data, even if they did have the skills to do so. So it's just making sure that we always have that human alternative and we're not excluding people.
Thanks, Sarah. I'm going to around dentistry. Can I ask who leads that? And Claire, can we ensure that Health Watchers fully engaged in our planning?
We can, and they are already. I mean, Health Watch sit around System Primary Care Committee and have been part of our dental deep dives before we took on responsibility for dentistry. We're about to set up a dental reference group which will include Health Watch and other members, sort of wider partners and stakeholders. But you can see from the projects here, as Graham said, we're determined to spend our full allocation, and dental services budgets are ring-fenced. So we've got an ability just to focus on dentistry. It's not just primary care dentistry, it's the whole end-to-end pathway. So we're also working with our providers to make sure that, the collaborative in terms of sort of waiting list initiatives and elective recovery, we're sort of delivering dental services right across the pathway.
Thanks, Claire. And could I just ask John just to make some comments on digital exclusion? Hugely important point.
Yeah, first, thanks for the challenge around joining up the communication. We'll absolutely do that in future. I think there'll be more of this, and I think technology is a huge part of many of our agendas, particularly in terms of recovery. It's not accessible to all, and our services have to recognise. So we have to have a bimodal approach. I think at a summary level, those users that are comfortable with digital and that are able to access services that way, it does reduce the demand on more face-to-face interaction. So there's a theme running through that, but absolutely recognise that challenge. And the invitation to coordinate comms, we'll absolutely do that in future.
John, can I ask at a future meeting, we just hear a bit more about what specific actions we're taking around supporting those people who are digitally excluded and are likely to remain. If you could bring that to
absolutely,
a future meeting.
Yeah, and there's a range of answers to that, but we'll bring a summary of the whole agenda.
Thank you. Neil?
Thank you. My question follows up on Sarah's in terms of the dental, and I think these initiatives are great and really welcome, and we can measure the contacts. What I'm unable to measure is the unmet need, and how does this help the unmet need and what's still out there. And I suppose my other observation would be a national review of a dental contract is really welcome, but now the budgets are devolved, I suspect we'll be left with the financial challenges of that. So are these initiatives non-recurrent in order to give us some flexibility when we know what's happening nationally, or is this committing us as well?
So, do you want me to answer that?
Please, yeah.
So the dental improvement plan is 23-25, so it runs over from sort of July, when we approve June, through to the end of 24-25. So that gives us sort of a period of time to hopefully sort of make some of these schemes both recurrent and resilient. And we will be reviewing, as Graham said, we do a sort of a reconciliation every 6 months with the dental contracts. So where there are underspends and underactivity, we'll use that money. So that 3 million will probably rise considerably. So we will look to increase the number of projects or increase the number of access and capacity opportunities. I think the dental contract hasn't been reformed since 2006. So nationally, it needs to happen. In terms of the delegated budget, you're probably right, Neil, but hopefully as we've had with the Primary Care Access Recovery Plan, which was launched in May. There was additional funding for that. So I'm hoping if there is a recovery plan for dentistry, there will be some additional funding and we'll get our fair shares of that, but that we'll have to see what happens in the future. Thank you.
Thanks, Claire. Claire, I think this will be part of your ways of working, but can we ensure that in those areas where we know we will be most challenged, talking about the health inequalities, duty of the board, can we focus in our attention on those?
So Ian, in his new role as Director of Population Health, and I've already met with the oral public health lead at the region, and so we'll be doing that, and that's the conversation we've had, but absolutely. And some of the initiatives, if you look at the, I'm looking at it, Project 1, in terms of the urgent care centres, we are commissioning a further 6 across the patch, and they will be based on the needs of the population and where the biggest gaps are.
Thank you. And that goes some way, Neil, to answering your question about unmet demand. Thank you. Are we happy to move on? Yeah, thank you. If we could go to the report of the Place Director, Mark.
Thank you, Chair. Can you hear me okay at the back? Just checking in. Yeah, brilliant. Good morning, everyone. Welcome. First of all, delighted to welcome you all to Liverpool here today. I'm going to spend the next 10-15 minutes just talking to you a little bit about the work that we've undertaken as part of the partnership to try and improve health and care outcomes in our city. I'm going to try and get the slides to work, so bear with me. Hopefully, Matthew, have I pressed the right button? Clearly not. Sorry, Matthew. Fantastic. Thank you. Sorry about that, everyone. So I'm going to start with a little bit of context about Liverpool. Again, many of you know this, but I think in terms of setting the scene for both the challenges and the opportunities, I think it's really important to do so. In terms of the health profile of Liverpool, we are one of the 7 core cities in England, which obviously brings a unique set of characteristics to the local system. Again, much of this is known, but again, it's really important for us locally to understand this, that around 63% of our population live within communities that are ranked within the 20 most deprived in England. That, at an overall level, means that Liverpool are ranked 3rd in the country, close to our partners in Knowsley, who are 2nd in that ranking table, so clearly sets out some of the challenges. And just the opposite side to that, only 1% of our residents live within those communities ranked as the least deprived in the top 20%. So again, you can see the stark differences there within our place. Again, some more, really challenging areas. Around 1 of 3 of our children live in relative poverty. And we also have a really diverse population, which I think sometimes isn't necessarily recognised. So in the 2021 census, around 1 in 4 residents identify themselves as part of an ethnic minority, as in non-white British. So again, that brings challenges in terms of the services that we provide, translation, interpretation issues, which again we know are so important for us in terms of communication. One of the clear differences that we do have within our city and within our place is the life expectancy gap. And again, much trailed this, but I think again is really important. There is a 15-year gap in life expectancy between some of the wards in our city, so particularly between the north and the south, and again some variation within that. And we know that brings challenges to service delivery models on a day-to-day basis. This slide again sets out some context and some of the challenges. One of the most challenging elements of this slide is that when you look at the details, is that 2 in 5 of our residents die under the age of 75, which equates to around 1,900 people each year. And based on some of the clinical views, around 1,100 of those are considered preventable each year. The causes, largely for those, are around cancer, CVD and respiratory conditions, and those are the main contributory factors, obviously, in the overall terms, but are often more stark than when we compare in those deprived areas, as described in the earlier slides. The other challenge that we have is that the growth in life expectancy has stagnated, definitely over the last decade, and we've also seen that gap changes between men and women within that profile. We also have some challenges in terms of the wider determinants, which again we all know are so important to our health profile. So 61% of our population who have a physical or mental health comorbidity are under 65. And we also know that 1 in 3 of our economically inactive residents who experience long-term sickness, that's a higher proportion than relative national terms. So we do have a significant amount of challenges which again are important to us. The next slide is probably a little bit difficult to read, but again, we wanted to share with you some of the things that we do look at as a partnership. So these statistics are part of what we would normally look at in terms of the life course, if you like, for Liverpool. One of the areas that we obviously focus on is not just the acute side of the world, but obviously on this chart you can see a range of other areas that cause us concern. So particularly around children and young people, and also drug and alcohol related issues, which we know further compound some of the challenges that we face in this system. So as you can see, there are some really significant challenges that the Liverpool system faces, but in equal measure, I would like to think that that also provides us a significant opportunity for the partners within the system to work together to improve and deliver some of those transformational changes. So Liverpool, as we know, is a large and complex system with many, many moving parts. We not only serve the local community, but also we provide services to the wider Cheshire and Mersey system, alongside many other regional and national relationships. So it makes our place system very complicated to navigate on a day-to-day basis. So despite all of those challenges, though, what gives us hope locally is the calibre of those organisations, many of which are on the screen in front of you. But equally the strength of the place partnership that exists within the Liverpool system, and that we're working together to try and tackle some of these really complex issues. The One Liverpool Partnership approach extends just beyond the health and local authority partnerships that you can see on the screen in front of you. And again, we've got really vibrant relationships with Merseyside Police, Fire and Rescue Service, and again, a really vibrant voluntary and charity sector, which really do look to make the difference in terms of improving frontline service delivery. And we hope that by working together, we can continue to address some of the wider determinants, which again we know has such a significant impact on the health of the population. Work continues really to improve these outcomes between the City Council and the NHS organisations. We've developed a number of strategies and plans, which again, many of which you've seen before. These are basically rotating around 2 key documents, so the Liverpool City Council City Plan and the One Liverpool Strategy, and that results in a more operational integrated business plan, which helps us guide at a local place level what our key objectives are for our operational plans in each of the given years. And again, we manage that through our governance processes. So that very much is in hand in terms of what we're trying to do. And the next slide just sets out for the 23-24 financial year what our aims and objectives are around 4 main key areas, which again link back to the ICB operational plan, and again we're working with partners very much on that basis. We wanted to highlight to you today a few elements of our local work, hopefully to try and give you a sense of what's going on locally, again in the context of trying to improve some of those really difficult, challenging areas. So the first one we wanted to highlight was around emergency care. And again, as you can see in the earlier parts of our presentation, some really difficult challenges. We know that the Liverpool system often experiences relatively higher levels of acuity, often driven by factors associated with the deprivation, as we've touched on, and including the wider determinants for health. This can often lead to those higher relative admission levels, longer lengths of stay, and a higher proportion of people with no criteria to reside in a hospital setting. And again, that extends just beyond the physical health setting. That includes the mental health challenges that, again, we've touched on in earlier parts of today's meeting. There are a number of actions already in play, and again, we're working with colleagues within the system and with the central team under Anthony's leadership around performance measures to make this happen. So there is a series of actions there that you can see are helping to move us forwards, with a real focus on reductions in length of stay, of which Liverpool is an outlier, and equally our NCTR performance, which again, whilst not the worst, we're certainly not where we want to be in terms of performance for our Liverpool system. This also ties in then to the Liverpool Clinical Service Review, and again a number of recommendations go hand in hand in terms of improvements that we're hoping to make within our infrastructure as we go forwards. The next item I just wanted to touch on was our approach to inequality. So again, we've made a real feature of that in earlier parts of the presentation. We have a real spotlight on that as part of our partnership approach. We bring that through our partnership board on a regular basis in terms of what are the key actions that we think we could take to tackle those determinants, both from a health and a wider social care perspective in terms of moving those forwards. So we're really looking as partners to reduce the healthy life expectancy gap within the city, make every contact count, and embedding prevention at every level. And again, we've got some examples of that on the slide. So really delighted that one of our PCNs are a real leader in this. We've got an example on the screen there from Swagger, who are one of our PCNs in the south of the city. They've got a real focus this year on hypertension and weight management, and some real good evidence base already starting to emerge about the interventions that they're looking to do. Again, we've got 9 PCNs in the city, so we're looking to obviously share good practice and make sure that that's recognised, and equally where others are doing really good things, make sure that that community works together for the best possible outcome. We've also got a number of other programmes that we're looking to help support through targeted interventions, so particularly through our investment in local primary care. So we have an investment fund called the GP Specification in Liverpool, which again is very much targeted on improving those pockets of deprivation and some of the services that are provided. Working with public health around smoking and vaping and immunisation levels, which again we know are really important for us within the city. We've got some really targeted programmes around, for example, the Healthy Lung programme, again, which is showing some real good signs of picking up cancers in certain cohorts of our population. And again, that's very much on a targeted approach. And again, working with our PCNs to support those local population profiles to look at the services that we think need to change in the best possible way. One of our ambitions for the Liverpool Place is to shift towards more of an overall approach towards population health and change the way that the system operates around the patient rather than the other way around. I'd like to just play you a very short video which will hopefully give you an emphasis about what that looks like for us on the ground.
Now we're facing another challenge, not related to health, but related to well-being as well. Employment, on economy, on family relations, it's become too complex. And we're talking about side-by-side complex life. We have to simplify the complex life.
For me, it's the services that are complex. I think my dad is quite simple and I'm quite simple, and we have these basic essential human needs, but the services are complex.
It more or less puts the blame on the user for having a complex life, but though their lives are only complex because their needs have not been met.
There's a whole spectrum of physical illnesses as well as the mental illnesses. They need to be coordinated.
I was absolutely terrified after my trauma and saw 2 men at my door, and I thought, what's going on? Why? Because I've been traumatised, didn't they look at what was wrong with me? And I was absolutely terrified, but I didn't want them to go.
Coordination of care, vital, because it doesn't happen now. Different agencies getting involved, duplication of effort, court cases that aren't necessary, all that happens. I see it, I know it happened.
The next day somebody else came, they didn't even know what had happened when the 2 men came. There was no notes, no follow-up. They expected me to go over it again.
It's to be less confused, it's to give them empowerment, ideas, build up strengths together, not to lose, be confused.
There is no health without mental health. So it's quite important for the whole package of looking after the service user, the carer, the communication between the clinician and the end user.
Somebody needs to be responsible for that. Somebody has an overview, and traditionally it was the GP, but that's not happening now.
I did ask whether My dad had someone allocated to him. The response was that yes, but they weren't nights. I've not even met that person yet, and I don't know whether they know my dad or not.
Reliability, trustworthiness, honesty, all those things need improving, and it extends further still into other agencies and proper communication and data sharing between other agencies.
There should be an expectation that we communicate and support the people who are having to access and use the services. Put them at the top of the tree. They should be the first priority.
I've got my resilience back to a high degree. That's not to say I don't suffer, but it's taken me 9 years. If they'd had the continuity which I was supposed to have, I think it would have taken me 5 years.
So some really powerful messages in there, and I think describes much better you know, what we're trying to achieve as a system, but very much so we're trying to bring that into all of the work that we're doing locally. And that very much is our ambition around population health, to very much have systems and organisations wrapped around the individual rather than, as you've heard on that short video, the other way around. We've got a very ambitious approach to population health. We've divided our population, if you like, into a number of segments, 5 of which we intend to focus on. So they're in the chart in front of you. So complex lives, frailty and dementia, long-term conditions, disabilities, and healthy children and families. And we believe they are, you know, 5 key areas for us to tackle, given, again, the population that we have. Our ambition is, again, as described on the screen, to move from the description of our current system, which is under that 2023 header, very much towards the right-hand side about what our system needs to look like to very much counter some of the challenges which, again, we've just shortly heard about. And I'm, you know, delighted to have Professor Joe Rafferty, who, again, is the Chief Exec from Merseyside, leading that on behalf of our local system. There's some fantastic work going, and, again, hopefully the fruits of that will be seen in the coming weeks and months. And one good example of that is that as part of our winter planning, we're looking to target you know, around 100 to 200 families who we think are at the most significant risk of being admitted into hospital over the winter months. So we're really trying to get ahead of the curve with that, with some risk stratification and some, you know, integrated working amongst our communities to try and preempt that difficult challenges in the winter ahead. What I wanted to touch on for the last couple of minutes is one particular area of our population health approach. We're testing out these approaches very much on a live basis. We're very lucky in Liverpool to have some fantastic people working on some really fantastic products. So again, you may have heard these terms used before. So Cypher and System P comes from very much some of the work that we did during the COVID pandemic, but is giving us lots of really positive outcomes in terms of the products that we can use to improve our way forwards. I just wanted to touch on the complex lives segment, which again, we've touched on before in terms of what Liverpool is trying to achieve. But first of all, what do we mean by complex life, and why is it so important to Liverpool? So using the definitions, which again, hopefully you can see on the screen in front of you, we think around 0.9% of the Liverpool population, which is around 5,000 of the adult population, have what we would term that complex life. So a range of interventions, interactions with the system, often on an unplanned basis, which obviously then consume a greater degree of the resource than perhaps you would want to have. It doesn't stop there, because obviously that then extends out into wider households. So again, you can see within the figures, building around those 5,000 adults, we can see that extends to around 19,000 people, possibly within our city, that again experience some of those really challenging circumstances and environments. And the most prevalent health conditions in those households, again, are all too common for us in terms of some of the challenges that we know exist. So particularly around increased levels of depression, anxiety and asthma. And again, we know that those conditions are particularly sensitive to wider social, economic and environmental conditions, and it's just really important, again, we can try and tackle that in the most positive way. From a health perspective, we know that obviously then brings a range of implications, again, as we've touched on, so multiple A&E attendances and hospital admissions, significant contacts with mental health services, and again, often in an unplanned manner, end up in service provision around drug and alcohol misuse, which again, we know is a significant use of our resources. So our aims are simple: reducing the number of people attending A&E or staying in hospital, improving access to mental health services, and also developing a preventative model so that, again, we can tackle some of the challenges that we know exist through the development of that longitudinal health record, as described, to try and help and support those individuals who are experiencing that complex life. Each of our population segments, and again this is just one example, has clear governance and leadership arrangements in place. They are drawn from partners within the system, including voluntary sector and some of our providers within the sector. Each has a set of programme priorities and action plans, and again we take that through the governance of our One Liverpool Partnership Board, and we really look forward to seeing the positive impact of that, as I've described, as part of our partnership work. And the slide just on the screen just gives you an example of what we're doing at the moment around the Complex Live programme. Again, we're hoping that has a real impact ahead of the winter months. So, in conclusion, I hope the last 15 minutes or so have given you an insight into what we're doing at Place, some of the challenges that we have, but also some of the hope and optimism we have about the opportunities that we think exist in terms of improvement. I look forward to continuing to work with system partners around doing so. And just to reiterate, we're really up for the challenge and really excited about some of the things that we think we can achieve. So I'll hand over there, Chair, if that's okay. Happy to take any questions.
Thanks, Mark. Before we ask Mark any questions or comments, should we have a look at the resident story? And then we'll come back to the presentation. Is that okay?
No. Sorry, Chair, it was in the slide, in the presentation.
Oh, was it? Yeah. Okay. Right, any questions or comments? Mark? Neil?
Yeah, can I ask a general question?
Yep.
I mean, it's the 75th anniversary of the NHS, but it's the 12th anniversary of Place. How does it feel, and what difference is that making?
I suppose the honest reflection, I've certainly Liverpool Place, and obviously I've only been doing the role since April, so relatively new in that sense. Liverpool, as you know, has been through quite a lot of change, politically, organisationally. But what I would say is I'm really encouraged and excited about the stability that seems to have landed now, and that there's a real strength of partnership working starting to emerge. We're really starting to get a grip on some of the tangible things that we think are going to make a difference. So I've referenced in the presentation, for example, about non-criteria to reside performance. We've got a series of weekly meetings now taking place with partners in the room, absolutely holding each other to account. Would that have happened 2 years ago, 3 years ago in the same way? I'm not sure it would. And again, I suppose I've got the benefit of being part of the Liverpool system, in older days. So definitely see a difference, definitely see a strength and a will to make some of these things happen. We're trying to not focus on 1,000 things. We're trying to focus on, a smaller number of things that we think will absolutely make the difference. And that enhanced sort of governance and reporting regime that, again, hopefully is coming through Place. Place is, it's a fantastic environment. There's some really, really good people within our system. We've got the benefit, again, of some partnerships within the system, academic institutions, some really vibrant voluntary and community sector organisations, which really help challenge our thinking. And it's not just about the health component, it is about that wider. So I'd like to be, 12 months' time, sitting here telling you all the good things that have happened and, again, how we've made that difference. But I'm really excited about what we think we can do in the Liverpool system.
Is there anything we as an ICB board can help in any way? Maybe just keeping out of the way is helpful, but is there anything you feel we can do more to help?
I'll try not to look at Claire when I say this, but, obviously resource and money is always, we've got some fantastic ideas. We're trying to make sure that our financial position is sustainable so that we can, get on with the things that we need to do. I think the operating model is definitely settling down. I think there's a clearer sense of roles and responsibilities, and I think it's just about continuing to work in partnership, with other places, with, the central team and, the leadership team to make sure we're making good, robust, evidence-based decisions. We do have to make some difficult decisions, I would say, but I think if we do that in the right way, that will stand us in good stead.
Thank you. Neil, Sarah?
Yeah, it's welcome Mark's presentation. So much of that is obviously really familiar. We have got so many challenges in Liverpool. It's almost daunting sometimes, the scale of the problems that we're facing. But I do think that in recent months it feels that there is more action happening around some of the inequalities issues. We've had the One Liverpool plan. We've all had the kind of the stated priority around inequalities for some years now, but we know the pandemic and the cost of living crisis has hit us hard and those inequalities have increased. But I'm increasingly seeing more and more that equalities feel like they're front and centre of a lot of the conversations, and that some of those are happening with communities on the ground. So some of the work that the PCNs are doing involving the community connectors and the community champions, and it feels that where we can build our solutions around people's lives and what actually matters to them and what works for them in practice, we've got a much better chance of them landing and actually being successful than when we rely on the numbers. And it feels like we're kind of getting the two together now in a way that we probably haven't in the past.
Thanks, Sarah. Graham?
Mark, so you know one of my issues would be if you're not measuring it, how can you know whether you're improving it or not? And one of the things I'm also incredibly conscious of is there are so many things that we could possibly measure, and working out how you measure the right things is important. But one of the things I was struck by listening to the video, and that's the first time I've seen that video, is do we measure how many of the people in the Complex Lives programme have a continuous named healthcare professional, you know, whether that be a nurse or somebody else? And do we try and measure in some way how that we maintain the continuous nature of that relationship, or the number of people who have actually got a named nurse or a named somebody else?
Thanks, Graham. I have to go and double check on the specifics. I know as part of the programme for each of the segments as described, there are an agreed set of metrics and deliverables about what they're trying to achieve, but I can pick up the specifics of that. But you know, absolutely makes sense what you're describing. That should be a core theme and aim of what that programme is trying to achieve. So I'll come back to you.
That's what I heard, listening to the people.
Yeah.
Yeah.
Well, just a question for me. So if we describe our local authority, NHS, our past approaches are about centralised control and doing to people. I know that's a gross exaggeration, but it's generally the theme of what happens. How is your place assured that you're actually being led by the needs and wishes of the community? And what feedback do you get directly from the community that says, yeah, we're making the progression to what they want?
Yeah, really good question. So again, if I touch back on the segments, you know, we've got real good engagement of each of those programme areas that we're looking to achieve. I suppose the reason why I always come back to it is we know that working in the traditional manners that you're describing, the silo organisational thinking, which again is a byproduct possibly of that, you know, we don't end up with the right set of actions, and we think that by changing our approach and, you know, wrapping our care in the way that hopefully we've described this morning, but a key part of that is to do things in the right way, in the right structured approach. So, you know, that co-production, you know, engagement, involvement, of what does that mean. And again, we're really lucky, you know, Sarah's fantastic in that, you know, she gives us lots of really valuable contributions, and others, partners in the system, about how we are getting things wrong, frankly, and how we need to make some of those things right. So again, in each of the work streams that we have, we've got real involvement and engagement piece of work about what we think we could do to make things better. And we constantly check in with partners about, you know, are we making that case? Can we do more? Absolutely. But again, it's a key part of what we think makes our programme a success going forwards.
Okay, thank you. We happy to move on? Sorry.
There we go. So I think a couple of the points have already been covered. But I think what that highlighted to me is the collaboration that's going on within Liverpool, not just across kind of healthcare agencies, but, you know, involving third sector, involving, you know, the difference between, I think pre-COVID, there were perceived structures and barriers in place that meant that we weren't able to work together in the same way. I think through COVID, a lot of those barriers have been forcibly removed, and actually what that's allowed for is conversation between different organisations, but particularly I think, you know, the spotlight on Swagger highlighted the, you know, primary care being able to interact with local food banks, children's centres, even local education, and actually it's bringing all of the services together that we can coordinate care and reduce duplication of services, and hopefully be able to remove the complexities that make people's lives complex. I really liked the point that she made where she said patients' lives aren't complex, it's the systems around them that are complex. And I think that's exactly, as an ICB, what we can do to be able to remove those complexities. So I thought that was a really good point to highlight.
Thanks, Naomi. A really, really important point to highlight. What does Swagger stand for? Is it one? It's one of the PCNs,
it's Wavertree, Egbert, Garston, Gattaca, Allerton, and what was the S? Speak.
Okay, thank you.
It was Swagger's a culmination of its two networks that joined together. So it was Wagger and South Liverpool, and then it became Swagger. So yeah.
Only in Liverpool.
Rowan.
Thank you. And almost at a different end of the spectrum of our community voices being heard, I'd also like to pay tribute to the work that our academic partners are making for Liverpool. We have a great university here in Liverpool, and one of its most enormous strengths with international reputation is the population health work. And what they've built with us, and you touched on the value of CIPHER, where times are difficult in terms of the resources that our NHS is being handed, our ability to find those in greatest need and a move of academic institutions away from pure ivory tower publishing papers and commentating into what they call action-focused research, actively solving the problems and demonstrating the difference it makes, and looking to disentangle the complexity because of our ability to understand it, is another enormous strength that Liverpool has, that we are investing in as a system, and I think is one of the key parts of our foundation to unlock and improve the health of all those we serve here. And I'm grateful for the very strong relationship that we have with them, with the NHS and social care. Thank you.
Thanks, Rowan. People are happy to move on? Thank you. Shall we go to Ian, health inequalities and population health?
I was
sorry.
just going to do
Sorry,
a very
Claire,
brief
yeah.
introduction, if that's okay. So I think firstly, just delighted to welcome Ian as our new and actually our first Director of Population Health. Obviously, Ian sat around the table before in his former role, but obviously started formally at the end of June. And I think based on the conversation we've just heard and the discussions around population health, I think it's absolutely critical that we have this role to lead our inequalities agenda across the whole system. And I think with the 20th anniversary of CHAMPS, the public health collaborative across Cheshire and Mersey, and obviously they've just gone past the first year of Altogether Fairer. So I think it's a perfect time for Ian to update on the work he's been coordinating across the system in his former role, and then give us a bit of an insight in terms of what some of the things he's going to be doing in his new role. So thank you.
Well, good morning, everybody. There's a lot of synergies. It's not by accident, is it, that what we've just heard from Liverpool. It's been brilliant to hear all the population health and the intelligence that goes in there. So we've discussed around health inequalities and also prevention at the Integrated Care Board on a number of occasions. So we wanted to bring a little bit of a summary and snapshot of the progress that's been made in the last year, 15 months really. I won't go through the paper in detail. It's in your packs, and there's a lot of good examples through there that we tried to capture. I think they would start off by saying we've just heard exactly the challenges and opportunities in Liverpool, but we cover 9 areas. We're one of the biggest IC integrated care boards in the country, and about a third of our population actually live in the most deprived neighbourhoods in the country as well. So that presents a real challenge for us as well. So there's no way we can solve some of these challenges on our own, and that's sort of the approach that we've taken around population health and the role of the ICB. So as Claire's alluded to, previously as the Director of Public Health, but we've been working with the 9 local authorities and their Directors of Public Health in developing the population health programme. You'll see from the paper there's a number of different strands under that programme. They're badged around tackling the social determinants of health, tackling the healthcare inequalities and around how our NHS and care services are delivered, some of the structural challenges that we've got, but also things like condition specific. So we hear that people have many different conditions at the same time, as we just heard from the patient stories. How do we tackle some of that rather than being in an individual way? And also importance around screening and immunisation. So a couple of things within the paper I just want to draw out for the board really. We have the Public Health Collaborative. It's 20 years old, as Claire's referenced. As the ICB are investing in population health, I'll be sitting on that board with the 9 Directors of Public Health to make sure that we are linked in together and putting together our assets, if you like, with the local authorities and community in delivering prevention approaches and tackling inequalities together. Each of our 9 different places have very different challenges, and it's important that we acknowledge those, and that's where the Directors of Public Health and local authorities play a real important role within that and being brokers and links into their systems. Some of the successes actually we've already been able to do with the ICB and CHAMPS includes obviously investment within there, but the Simple Things campaigns, the health protection campaigns as well, got international recognition. We heard from the last board where you supported the electronic vaping statement by the Directors of Public Health. That's actually received a lot of positive national reinforcement, what they call on, to removing the disposable vapings and the importance around tackling that and how they become available to our children and young people as well. So the power of us coming together really is there, and the ICB has a really important role to play with that. That kind of brings us also onto something that the ICB that you've heard before is mentioned, Altogether Fairer. It's a massive programme of work. We asked the Institute of Health Equity, Sir Michael Marmot, to work with us to become a Marmot community, if you like. And one of the things that we've been able to do is get absolute unification across the 9 local authorities, their health and wellbeing boards, about the importance of tackling those causes of ill health and structural challenges such as housing, employment, structural racism, which is great to see at the next agenda on the item, come to the ICB today as well. So the healthcare partnership is also new. And last week that was webcast and available to be watched back as well. We looked about sustainability, climate change, the role that the NHS has and our providers about being stewards of our society, these things called anchor institutions, how we can reduce our carbon inputs as well. But that has to be done together with our local communities and the local authorities on that. So I would steer towards that work as well. One of the things that we referenced just at the beginning, in September, there plans to be a dedicated workshop around health and housing and the implications we just had, a number of certain issues that are coming up again there. We can't do these things in isolation, and the power of doing that across 9 areas, again, comes under work of the Population Health Programme referenced in the report. Some of the progress that we've also been made is about the importance of fair employment as well. We know the links in between importance of health and the impact that has on the economy, as well as our own staff and many staff across our sectors. So we've been working with Liverpool City Region on the work they've been doing on making employment fair and mental well-being that they place in their occupational health and support. And I'm glad to say the Cheshire and Warrington colleagues have joined up on that agenda as well too. That work got referenced in the 1-year-on celebration that we did last month now with Sir Michael Marmot. So that was really positive and just shows the challenge that we've got across the 9 areas too. In addition to, we mentioned the difficulties around that, we measure through what are called beacon indicators that we've agreed on. We've got to go to a next phase around that. So the beacon indicators are 22 indicators around 8 different themes about how we're getting on about tackling these inequalities. If we don't measure it, we won't know we'll progress it. The next stage is to actually really get into more of the population health management and data to say, well, how are we targeting those most impact of some of these issues? So a good example would be of that population health into action was the fuel poverty work that we might have mentioned before just before last winter, bringing together the data, working with our local councils, our GP practices, our voluntary services to work out who's most at risk of the fuel poverty agenda, how they can get the right welfare support in place and mitigate some of those really tough challenges that our communities really face. And we've been able to build on that, and it's a good example of a theme in practice about what we can do together on that. Healthcare inequalities. These are things that Mark referenced as well about trying to find people who need who would benefit from tackling their high blood pressure, looking at about how they manage their respiratory conditions as well, but also for those in our communities who have some severe mental illness as well. So you'll see some references in the report about especially some really good work in St Helens around targeting some of the health checks within that and working with our most vulnerable populations. The Population Health Board, again, to oversee some of the good practices in those 9 different areas, but each has different communities. So it's really good to see that lessons learned and how we can scale that across the 9 areas as well. The ICB also has a responsibility around a number of different preventative programs. That includes tackling tobacco and supporting our provider trusts, but also reducing the harms from alcohol as well. And what we're trying to do is bring all these many different programs together so that we can have a coherent approach to that. And You'll see that within the report. A good thing to highlight, and I just want to say thank you to our providers, representatives around the table, is the NHS Prevention Pledge that we've been doing. This is working with all our different NHS providers about the benefits of getting upstream, working with staff, the Making Every Contact Count programme, and there will be for the first time a summit bringing everyone together on that in September as well. So I'm very grateful to that whole system approach of what we're trying to do. I will just finish up by highlighting a couple of things in the paper. You can see towards the end in figure 2 some of those key conditions that are impacted across all of our 9 areas. So a big piece of work that our analysts that Rowan referenced before come together with the universities, our local authority intelligence analysts, our NHS analysts, our community leads as well, is to identify what those priorities are in different areas to go at. You'll see things like cardiovascular disease, stroke, the respiratory issues, cancer. Not an incredible surprise, but there are other things that all 9 areas are struggling with, including falls and how we're preventing falls across our 9 areas. And then you'll also see reference to how we're using the Combined Intelligence Popular Health Action Platform and System P about those complex lives, which is a really good example before about actually many people will be suffering with a number of those conditions. We are going to be establishing and working with both Anthony, Fiona and Rowan's team an Intelligence into Action board that will drive forward where we target our resources and opportunities around population health management. And the crucial thing is how we do that at local areas as well, so we can support those who most need the support we've got in place. And finally, myself and Fiona, we've been working on a number of things with the UK Health Security Agency, some of the health protection threats that we face still. There is a rise in measles that we've been seeing, so we're responding how we do to that and how we can eliminate that. We have migrant health challenges as well, including TB. So there's a number of programmes that we're doing a part of that population health, because screening and immunisations is still one of the best public health things that we can get done and right. I'll stop there, Chair, if that's okay, and welcome any comments or questions.
Thank you, Ian. Chris? And then Tony? And Steve?
Thank you, Ian. A good paper and some paired up with Mark's presentation, some stark statistics. And I think my question is around the contribution that the ICB and the ICS can make to this, and I'm thinking in respect of the workforce. So I don't know the exact figures, but I am making an assumption that a large percentage of our workforce live within Cheshire and Merseyside and have a contribution to make to this. I was interested to read around the Walton Centre and the Prevention Pledge, and so my question is around how do we as an ICB and a wider ICS create champions or advocates to support addressing health inequalities within the area in which a large number of our workforce will live.
Thank you. So there's actually, that's really positive, and I'd welcome the ICB's support of it. There's actually some good things already happening, alluded to within the paper. So we have clinical leads of health inequalities, thinking about our elective recovery programme, and Sinead, who leads that with health inequality in that piece. We had the primary care strategic framework as well, was being embedded within that, and local place leads around that. We also have some core, what's called Core 20+5 ambassadors. One of the, as we come into a bit of a transition, my ambition is to bring those inequality leads together in a forum. The Population Health Board has grown, but actually there's a really importance to bring that forum together on health inequalities leads, working with some of our GPs who are developing the deep end practices, for example, and think about where those workforce champions are in our trusts and wider. It builds upon, actually we have 9 what we call MARMA or altogether community leads in each areas that are big advocates really about driving some of those social determinants change. So it's how we bring that neatly together. So I'd welcome that, and if anybody wants to support me with that, we'll take them up on it.
Thanks. I can see Chris nodding, so, but you've got a supporter there. But Tony next.
Thanks, Raj, and thanks very much, Ian. You mentioned earlier on the impact of the demand for a countrywide ban on disposable vapes, which was very welcome. And just underneath it in your paper, you speak about the new prevention framework, and then follow on by explaining that its scope covers smoking, alcohol, physical activity, healthy weight and mental well-being. Is there an element of that specifically targeted at children and young people? And in other words, a different offer for that segment of our population?
So that's, thank you. So that's trying to capture all these different programs that are going on into one that we're trying to do as a prevention framework. And with regards to our children and young people, it's worth referencing the valuable work that our Beyond group are doing around that. So that's what brings together, again, Alder Hay, our leads, our clinical leads at higher education institutes, our directors of children's services, and they were one of the areas, our ICS and their work was one of the areas nationally to be chosen to work with Bernardo's around the importance of improving children's mental health as well. So what we try to do is enable that engine room to focus in on children and young people's well-being and public health needs. There is a separate, in the appendix, you'll also see a separate framework called for children and young people's NHS Core 20+5 with specific priorities around epilepsy, diabetes, childhood asthma, etc. as well.
Yeah, thanks, Ian. And that's the heart of this. When I look at the Core 20+5 for children, it's focused on particular health conditions in children. But what I like is the general prevention framework you've got there to focus on healthy lifestyles, weight, avoidance of alcohol and so on. Can that be translated into a specific programme for children?
If I could just come back on, I suppose one of the real important things we need to be careful of is the structural challenges our communities all face about that. So it's about supporting those healthy lifestyle behaviours, whereas a lot of our communities are challenged by what's around them, and whether that be what's on the high street, access to affordable leisure services, children's centres, etc. as well. So I suppose it's just being careful how we frame that, because not all, as we know from the childhood poverty challenge, not every child will have that same access or be easy to do that. We work together with the Beyond group around that, so I suppose that's to give you some assurance how we link it up.
Thanks, Tony. Steve?
Well, first of all, Ian, really do welcome this paper. It helps us get on the road to fulfilling one of our strategic objectives as a board and as a system. And I do welcome the genuine partnership approach that you're adopting here, and the fact that the population health programme will add value to the work that's going on in the 9 places. And each council, each area has its own JSNA, which analyses issues around health inequalities, and that acts as the core for each individual health and wellbeing plan. And if you can continue with this sort of bottom-up approach, I really welcome it. But of course, there are some things that need to be tackled at a more sub-regional level, including, as you said in your report, Ian, issues around additional funding support. I would just hope that moving forward, we have to have a very good evidence base around health inequalities, which is linked, of course, to inequalities in society, which seem to have grown over the last 13 years. And I'd like us to ensure that we have some actually focused interventions. I mean, I come from a sort of school which says, I welcome the evidence base, but sometimes I notice this paralysis by analysis, and I'd like us to take some brave decision around some interventions around our patch around reducing health inequalities.
Can you not hear? I'm sorry. If you've got some questions, we'll take them at the end of the meeting, and we'll get you a response. This is a meeting in public. Okay, we'll come back to you.
So first of all, I value that support. We've worked very closely as assistants to do that, so it's good that we are getting that right, and we'll continue to do so. Actually, I think that we've been brave in the entirety around the work that we've done on Altogether Fair and making that statement as well. So it is good ground, but it is about delivering now. And I think the crucial thing is where we put that finite resources in place in local areas that make a difference. So that's something we're working with the healthcare partnership about, which is, I suppose, it's that bridge into that wider determinants of health. And we'll be working with local leads about what will work and what will complement the local inequalities programme as well, really. So thank you, Stephen.
Thanks, Ian. I think it's if I could just add, the healthcare partnership, this is its space, and it's very soon, September, we'll have specific programmes, which will they'll meet your challenge, I think, Steve. And I've got Hilary.
Hi, yeah, thanks, Ian. Great report, and I think what impresses me is the real sense of ambition. My point is around staff and the alignment of how we recognise their staff health and wellbeing challenges. The people who are going to execute making every contact count will be our frontline staff. And it's very difficult when you've got health challenges of your own, be that alcohol, smoking, weight management, or just as a few examples. That's the first one. And we almost need to ramp up how we support the health and well-being of staff, being given what they've been through and the busyness of the system. And I think my second point is the inequalities that our staff suffer as well. And I'll give you an example. It really concerns me that nurses have the highest incidence of domestic violence and suicide, and what that then leads to in terms of the health burden and inequalities that they carry. And I think the second point is victims of racism as well, and how that affects people on a cellular level. And these are the things that are rarely talked about. So I think it's something about how we recognise our staff. If we don't pay attention to the staff health and well-being and inequalities, it's absolutely fundamental to this strategy, these ambitions being recognised. Thank you.
Thanks, Hilary. That's a great point, isn't it? We can see data in other papers. I think our staff sickness absence in the NHS is 7.5%, is it, Chris? Something like that? Or, so 6%. Okay. So it disguises the extent of the stresses and traumas at our staff. And we've got 77,000 staff, I think, in the NHS. I don't know about local authorities. There must be equivalent, mustn't there, and voluntary sector. If we could seek to influence them where we've got some more direct relationships, that's a really great ambition to have.
And in turn, they influence their families and their local communities. So
absolutely
it's
great.
You know, yeah.
Thank you. Neil?
Yeah, I think it's great, Ian, what's taking place, and there's an enormous amount of work taking place, and a lot of it should make a difference. But it's how do we know it makes a difference? And I don't know. I just wonder if there could be a dashboard which talks about maybe the contacts for something that should make a difference, but also the outcomes, so that we can focus on. Some might be long-term, some might be shorter-term, but so much great work, but how do we know it's making a difference?
And that is the right challenge to do, because I'm trying to make the case for further investment, so we've got to show it delivers. The work we have put into place has got strong business cases in place that we've done. Both of it marries up to also national direction. So, for example, in the forthcoming what's called a major condition strategy nationally, we believe, in the new year, it focuses on 6 conditions. It's no surprise that actually we're already aiming towards that, and the work that we're doing in intelligence, that there's a lot of secondary prevention measures that go in that we're implementing. You've heard about the high blood pressure case finding work as well. And we know that will save both lives and other costs to the system. Where we do have to be a bit more innovative, though, is those local bottom-up approaches with communities, listening to our communities, what needs. We're investing in the community sector as well. And what we try to do is certain logic models where you say, well, these are the outputs and how are we going to get to the outcomes. But the challenge we've always got is that some of this doesn't deliver overnight. So I think one of the sections in the report that I referenced to around population health intelligence and the intelligence into action is so important for us to monitor the progress that we're getting made about the investments that we're putting in, and that's sort of in the next transition and stage that we want to do.
And just, Neil, if I could just, and it's important to emphasise, I think, Ian, that our first go at looking at the data is the Marmot Beacon indicators, and we expect to see that coming through the performance report, so it will give us an overview of where we're going. Okay. Paul?
Thanks, Siraj. Just to say, a lot of the work we undertake at a local level isn't just about trying to reduce health inequalities. It's basically about keeping people alive. So it's funding feeding programs for children during the holidays, supporting food banks and increasingly food pantries, enabling people to have access to decent fresh food. But a lot of what we concentrate on is emergencies, people in crisis and an emergency state. So hopefully in due course, and I won't say what the main event may be to make that happen, that we can move past just providing those emergency provisions and looking at the very short term into making that longer term difference. And I know that's the aspiration of the Altogether Fairer programme, but to a great extent we're concentrating on the here and now and the incredible challenges that are there.
Thank you, Paul. Really important. Very quick comment from me because we're running out of time for this meeting. Great paper, Ian, and at 4.43, figure 2, that's an excellent figure or diagrammatic representation of something you've termed the emerging population health priorities. You say emerging. How do we take that to be, solidified and through this board?
So what we've tried to do is bring together what the data and everything is telling us from the variety of different sources where it kept. We also recognise, though, that especially through a healthcare partnership, that priorities might be additional in different places, what they are. So, for example, they were very clear in a workshop that we had that importance around workforce, which is great that we're hearing about the workforce here, both in recruitment, retention, and looking after public sector workforce across all many different partners. Their priorities obviously framed around getting upstream and prevention within there, as well as also children and young people. And so I suppose it's the priorities that the data tells us, but also then we've got to combine them with what the local priorities are, where the action is sort of happening. And what we're trying to do is try and give a good framework for that action really overall. Okay. And sorry, just to find the one thing we do just need to be mindful of is that how we've split them by conditions are important. So we need programs of work after that, but many people will have, as we hear, multiple conditions that we just need to be mindful of.
Thanks. The importance I see of this diagram, it's a way for the board to look at overall our population health programme. So as that evolves, I think it's important to bring that framework back to enable us to see, because there's so much going on. Claire, last comment?
Yeah, just on that talks to our interim HCP strategy and our joint forward plan, yeah, and the prioritisation framework. So we have used that diagram and all the work and the evidence behind it to form the basis of a number of our sort of work. So I think it's important that we come back to this, but I think, as we've talked about, if we sort of triangulate that with the marmot indicators, I think that gives us a really good picture of where we are.
Thanks, Claire, really helpful. So this paper was here for noting. I'm going to summarise. There was three sort of overall comments I'd say for Ian and colleagues to think about. How do we get more staff and colleague champions to take forward programmes or advanced programmes? Healthy children. We've of course got the Shadow Children's Board to be established, and we'll ask that board to look at it. And finally, really important stuff about indicators, understanding how this board remains cited on progress of the actions and the outcomes that we're expecting from population health. If I can go on to the next agenda item, that's Chris, the North West Bayham Assembly Anti-Racist Framework.
Thank you, Chair. I think we're incredibly fortunate in the North West to have the NHS Bayham Assembly, which was formed by some of our senior leaders from across the region back in 2020. And that was very much about making sure that we've got a real strategic approach to making the NHS anti-racist by tackling inequalities in outcomes and experiences for both our staff and our patients. We know that racism is still very real, both in society and across the NHS. And despite a number of historic pledges and commitments and calls to action, we haven't seen those health inequalities and equality and diversity issues reduce. Racism and discrimination are proven to be major drivers in health inequalities, and I think we've heard that already this morning in a number of the reports. The North West Bayham Assembly Anti-Racism Framework has been developed as a tool designed to support all NHS organisations to become intentionally anti-racist by tackling structural racism and discrimination through collaboration, reflective practice, but also by holding people to account, holding them to account for their individual and collective actions. The framework recognises that continuous and sustainable focus is required to actually make a difference. And I think in the past we've seen very much one-off exercises to look at how we become more anti-racist. In the framework, you'll see there are 3 levels of attainment: bronze, silver and gold. I think that's really positive in that it encourages that continuous reflection and focus on this agenda. In your papers today, we've purposefully produced a copy of the framework. I think it is really important that members of this board understand the context in which that sits. And there are 5 anti-racist principles, which today I'd like you to all sign up to. The first one is about prioritising anti-racism, so making sure that we give this agenda the same level of resource, focus and attention that we give to some of our other priorities. The second one is about understanding lived experience. It is absolutely everybody's responsibility to tackle racism, but we also need to have meaningful involvement of people who have lived experience of racism or have experienced a whole range of discrimination. And that will ensure that the decisions about how we tackle racism are actually informed by real insights and reflect the challenges that people in our communities absolutely face. But as well as hearing about those lived experiences, we also need to empower our staff. We have really talented staff from a wide range of ethnic minorities, and we need to create the right environment to support them to help us make appropriate decision making. But we'll only make those changes if we grow a culturally competent board. And I think that is really, really important, that people around this table understand the experiences of our ethnic staff and our communities in which we serve. But it isn't just the responsibility of our BAME leaders around this table and in all of our providers to actually raise issues about equality and diversity and to challenge the decisions that are made. So everybody around this table is responsible, and I would ask each of you to view every decision that we make through an EDI lens. The third principle is about to grow inclusive leaders, and we have much work to do in this area. And I think you've only got to look around this table today to see that we don't represent the population that we serve, and indeed we don't represent the staff from ethnic minorities that exist in our organisations, and therefore that is an important piece of work that we do. The fourth principle is about acting to tackle inequality. This board will receive, as it always does, the RES data, so the Workforce Race Equality Standards, but that isn't enough. It isn't enough to say that we'll have an action plan. We need to take some real positive action where we see cases of harm, and we need to tackle that collectively. I think for our workforce, we'll be looking at our workforce policies and our processes, but for our communities, we also need to look to work effectively with our partners to make sure that there are no barriers that stop our communities accessing our services because of the way in which we deliver services or the publications that we put out there that are not inclusive. In the paper, we've produced an implementation plan starting today, where I'm asking the board to demonstrate its commitment to becoming anti-racist by publishing an anti-racism statement which details our commitment to race equality across Cheshire and Merseyside, and I'll be asking the board to identify a champion and sponsor for this agenda. It is then proposed that we undertake a really robust organisational readiness diagnostic across the 9 places. I think Steve made a really important point before, that each of our 9 places are all very, very different, and therefore it's appropriate we do that at each of those 9 places rather than trying to do one assessment for an organisation. That will then inform the baseline. It will help us to identify our priorities and the areas of focus that we'll map against the anti-racism framework. We're then proposing that we create a steering group to undertake a check and challenge against that self-assessment and to work with us on that diagnostic to support a programme of work. Following this, we're proposing that we hold a framework launch to publicise those priorities, and this will be an organisation-wide. It will be mandated and it will be an anti-racism awareness raising seminar. But we recognise that there is no point in the ICB doing this alone, and therefore we also need all of our NHS partners across Cheshire and Merseyside, and indeed our wider system partners, to work with us on this. And the People Board in Cheshire and Merseyside have allocated a small sum of money to put some support behind that and some dedicated resource. So I'm asking the Board today, Chair, to approve the adoption of the North West BAME Assembly Anti-Racism Framework and to support the approach that we put in the paper, and then to actually make our public pledge and to publish that anti-racism statement on our website, and that we'll receive regular reviews at this Board, but also I would ask that we review every paper now through an EDI lens.
Thank you, Chris. Any questions or comments? No. Sarah?
Just that over time it would be good to see it expanded to reflect more of the lived experience of the communities, because it's very staff and board focused at the moment, and obviously there's an organisation that may be what you want to put your attention, but we do know that there's a lot of experience of people who their experiences of healthcare and their experience of accessing it are affected by their life circumstances, including their race and origin and their language in some cases. So it'd be good to see additions for that.
Thanks, Sarah.
So, Sarah, I think it's important to note both Chris and I have a sort of joint leadership around EDI. So obviously Chris for sort of the workforce and sort of the corporate side, but myself for the sort of the commissioning and service development. So I think we both jointly bring papers here, and I think it's important to build this into that commissioning cycle and all the work we do going forward, both a strategic at scale work across C&M, Cheshire, Merseyside, ICB, but also into the places. So I think I'd be looking to do some work with Chris to see how we embed this in some of that service improvement development work as we move forward, and particularly into the 24-25 planning round. I think that's important as well.
Thanks, Claire. Graham? Hillary first. Sorry, Hillary?
I think this is really welcomed. I think there's a bit of an alignment or recognition that this will deliver our performance. So it's absolute importance, and the parallel profile and the right investment goes into this. But it's that narrative. If we improve this, we improve our performance. We improve the way we tackle inequalities. So it's looking at this as an integral part of all our performance measures, and not aligned to. And as we do get more into the detail, I'll be really interested in relation to how we support accountabilities from an individual level. So what does this mean for a clinician? We know systemic racism affects clinical practice. There's lots of evidence around that. So how do we as a clinical community talk to our clinical leaders about that, whether that's primary care or whatever? Making that really visible. This is part of your code of practice. To the chief executive, in organisations, how do we hold chief execs to account, and how do we hold the ICB to account? Having a practical consensus view of what that looks like would be really powerful. Thank you.
Graham?
The first thing I want to say is I fully endorse this. If my analysis, and I think Hillary's just said it in slightly different words, there's a business case here as well. Yeah. If we don't get this right, we won't deliver a shift in health outcomes for our population. If we don't get this right, in the longer term, we actually won't have a workforce to support our population. So behind this, we must remember this isn't just a moral case, there's a business case here as well. The second thing is, as Chris said, there's been a number of attempts to shift the dial on this over the years, and it always feels that we don't quite get there. So for me, I'm already talking to Chris about some small practical actions that could actually start to embed this in our culture. So available for every single member of our staff. We have an online training programme already available on equality, diversity and inclusion. And what I've said to Chris is, how do we now implement a policy that says nobody will be allowed to advertise a vacancy in their team, nobody will be allowed to sit on an interview panel to recruit a future member of our workforce unless they can prove they have done their EDI training. And at our internal staff briefing this week, I actually put up my home screen from my electronic staff record just to show everybody that I'd done mine. Yeah? And it is that powerful message that, you know, we've made the training available, we have to make sure that we do it. And again, the conversation with Chris's team is then, how do we go further than just the EDI online package? How do we then make sure that we have training for unconscious bias and a whole range of interconnected matters? So this is really, really important to us. I think this sets out the moral case clearly. I would say there's a business case as well. And so thank you for this. And let's make sure we can prove to the board and our population we serve, and then the BAME Assembly, that we're progressing this.
Thanks, Graham. So just some comments before from me before we go to the recommendations. So I'm part of the North West BAME Assembly since its inception, and obviously you can see from the colour of my skin I'm part of the group that has been talking from it. Yeah, this framework was actually launched 14 months ago, I think, and chairs and chief execs received a letter from Amanda Doyle, the regional director, to say, have a look, can you adopt it? And we've had really, really poor adoption across the Northwest, apart from some notable organisations. Because she's sitting here, and it's one of those organisations whose chair is really active in this field. And I found myself thinking, well, why does it take such a long time to really see action, or even, you know, for boards to discuss this topic in this sort of way? Undoubtedly, there is people are not comfortable with the term anti-racist. I've talked to individuals about it, and they feel, uncomfortable about using that term. But it is what it says on the tin. Really, this is what the framework is about. And if people do feel uncomfortable, I'm very happy to have conversations with people to help, you know, understand how we can transition to a place where people feel really positive about the term and the work that we're doing. So as I sit here, I'm going to remain sceptical about the progress that we make, because over the last 30 years in the NHS, we have not made huge amounts of progress despite initiative after initiative. I'm going to guess, Steve, for example, Paul, it's the same in the local authorities. So I do need the board to be hugely supportive of this. It is really important, both the moral case as well as the business case. But it's difficult, it's challenging, otherwise we would have sorted it. Paul?
Thanks, Raj. Just on your comment about people being uncomfortable with the term anti-racist, well, I think maybe then we've got a duty to try and persuade people to be comfortable with it. It may be that they see that it's in some way political. I don't know really, and I know some people have difficulties with concepts. They feel that. I think we've just got to get over to people that having a racist view is not justifiable in any way, shape or form, and doesn't form the basis of any sort of political argument. It can't be justified in any way, so that we really have to be passionately anti-racist in everything we do and everybody that we speak to, and be as vehement as we can when people try and resist the sort of concepts that have been laid out today, because we know that racism brings about poor health. It brings about poor mental health, leading to poor physical health. it's a blight on communities. It divides communities, and we really got to stamp it out as much as we can. So everybody really should be passionately anti-racist around this table.
Thank you, Paul. Thank you. So if we can move to the sorry, I have two things that I think have come out we need to note, Chris, for the paper. One is Claire's offer around ensuring we have synergy or connection alignment with the commissioning framework for 24-25, and Hillary's hugely important to point about accountability. Let's seek to understand how we're going to describe and see that, and there was a focus on our clinical staff as well in terms of the leadership role that they will have. So with those additions, the recommendation for the board to adopt the anti-racist framework and the proposed implementation plan. Are people happy to do that? Yeah. Thank you. If we could go on to the assurance framework.
Thank you. So you'll remember that the board approved the board assurance framework and principal risks in May early this year. So this report provides an update at the end of Q1. We have 10 principal risks, 4 of which are extreme and 6 of which are high. And you can see the most significant risks in 1.3. I'm not going to read the whole risk, but you can see the scores ranging from 15 to 20. So there's been no movement on these scores, which probably isn't unexpected since May. But we are making progress in the mitigations, controls and assurances, and myself and colleagues will be happy to talk and answer questions about those mitigations and the work we're doing. You can see in 4.3, this details the principal risks, which are just below the sort of extreme and high. And we are having a positive impact on these. But I think the key thing here is we have to make those impacts sustainable. So we might have controls and measures and mitigations, but it's about keeping those going all the time and not just a one-off activity. So again, happy to talk, answer questions on those. But obviously, the more we build on these the mitigations and controls, we will be able to hopefully bring the scores down so that we can move things forward. But we do have further work to do in terms of the risk appetite as a board. We've set out the level of risk exposure that we find acceptable, and we detailed that in the risk appetite statement we signed off in May. But we do need to do some individual work on our risks against the 4 strategic objectives of the ICB. So some of that is detailed in the report. We have set up a risk committee, as we committed to the board. We had our first meeting, and as part of that meeting, we reviewed the corporate risk register, but we did feel that further work was required on the risk register, both in terms of making sure it covered the full responsibilities of the directorates and the places, but also that was greater consistency in how we scored the risks across place and corporately. So we've got another meeting next week, and we'll be doing some further work and bringing that back to board in September. So I'll leave it there, if that's okay, because obviously we discussed this at Audit Committee and the new Risk Committee, but I'm sure colleagues around the table are happy to answer any questions. Thank you.
Thanks, Claire. Hugely important piece of work. Any questions or comments? Okay, so got a couple of comments from me. Firstly, thank you for the leadership and everybody's contribution to this really, really important work. It's maturing, and it's really good to see it's maturing. There's still some work to be done, I'm sure, around consistency and moderation. And in particular, I'll just pull out, if we could keep on pushing that maturity curve, especially around the controls and the descriptions of the controls in these risks. It needs a bit more work, and through the risk committee, I think, if we could ask the risk committee to pay a lot more attention to that, that'd be good. If people are happy with that, it's here for approval. Are people happy to approve the MAF as we see it today? Thank you. Operational planning, Anthony, if we can go to that paper.
Yeah, thank you, Chairman. Paper for noting here. Board members will remember the debate around the submission of our operational planning for 23-24, which obviously incorporates all aspects of delivery, workforce, finance, That plan was submitted on the 4th of May following board approval. The purpose of this paper is to inform the board of the feedback that we've had from NHS England in response to that plan submitted. There's nothing in terms of that feedback that we would necessarily see as new risks emerging, but there's some clear expectations, particularly in terms of financing some of the controls that they would like to see embedded within the system. I'd like to provide assurance that is there. Claire can probably confirm from a financial aspect. We've highlighted how the ongoing assurance will be managed through committees and through to board. That's evident in the papers that we see on a monthly basis. So it's really there for noting and completion. And there's a copy of the letter that we received formally from NHS England for board members' awareness.
Thanks, Anthony. Any questions or comments for Claire?
It was just to add to that, just to provide a little bit more detail on the way that we're dealing with the financial requirements set out in the letter. So the letter's gone out to all provider organisations as well in our system, and there are a number of requirements in here that set out around financial controls and deficiencies. So it was just to say that Graham has, on the back of this, written out to each chief executive in the system. All organisations are taking a view on their own internal controls in terms of complying with the requirements set out in the appendix to the letter. And we're receiving a formal note back from each organisation to provide assurance about the processes that they have in place. We will be doing that for our own organisation as well in the ICB, and that will go through the Finance Committee. And we are also establishing a expenditure controls group across the system to provide assurance through our committees on behalf of the system that those organisations in deficit are complying on an ongoing basis, on a monthly basis, with the controls as set out in the paper. So we've got a number of things in train to ensure that we are making the appropriate processes and controls and providing assurance to our committees that we have got that in place.
Thanks, Claire. Paper here for noting. People happy to note it. No further comments. Thank you. If we could go to the NHS long-term workforce plan. Chris, please.
Thank you, Chair. So the papers details the new NHS workforce plan that was published on the 30th of June, which sets out how the NHS will start to address both existing and future workforce challenges, looking at things like recruitment, retention, but also how we work differently, how we utilise technology, and how we make sure that we utilise digital advancements. The government have invested an additional £2.4 billion to fund additional education and training places over the next 5 years, and that's on top of the existing funding commitments. So that equates to an additional 27% expansion of training places by 2028-29. As you'll see in the paper, the plan provides a huge amount of detail in terms of numbers of additional staff that will be trained, but it focuses on 3 particular areas: about how we train more staff, how we retain the staff that we've got, and how we reform the way in which we work. And whilst it's a national plan, it is really clear that decisions have to be made at a local level and delivery has to be made at a local level. But most importantly, it talks about routes into careers in the NHS will need to change through radical development of things like apprenticeship schemes and reform of medical education and clinical education. But the plan is really, really clear that NHS staff, that volunteers and that learners in the NHS don't always have a good experience. And they don't always have a good experience of working with us, and therefore they take the decision to leave. And so we need to also look, as well as training and development, we need to look at culture, at leadership, and about creating the right and safe, inclusive work environment. The plan also assumes that it's not just more of the same, and there's a really ambitious productivity assumption in the plan that the staff that we employ will actually become more productive. It's important to say that the plan includes primary care as well as our NHS providers, but it is titled an NHS workforce plan. But it is clear that we as an ICB have a responsibility to work with our partners in social care, with the voluntary sector, to make sure that additional staff have opportunities across the whole of the sector and that the whole sector benefits from having additional staff trained. The plan is really clear that significant training expansion and workforce growth is only possible if we create additional clinical placement capacity, and we know that that is a challenge with teams that are already stretched. But we also know that the plan states that the introduction of ICBs and ICPs provides a unique opportunity to develop really robust workforce plans, including new models of employment, so looking at joint appointments across organisations with our colleagues in local authority, giving staff the opportunity to work across health and social care organisations. But we also need to look at the impact of things like artificial intelligence and automation, which will augment rather than replace staff. So it's a very different plan. The plan also provides specific expansion numbers for each of the disciplines, and so in the document you will see the plan to increase every single clinical role within the NHS. As I've mentioned, a key component of the plan is an expansion of the apprenticeship programme, which provides alternative career pathways. We know that apprenticeships also widen opportunities for people from all backgrounds and underserved geographical areas to join the workforce. And I think it's really important, particularly in the cost of living crisis that we've seen, where we know that lots of our local families haven't been able to support their youngsters going to university this year, that apprenticeships provides an alternative route. There is also lots of evidence that apprenticeships and people on apprenticeship programmes are less likely to leave training than those in traditional undergraduate training programmes. The plan commits to supporting ICSs to develop local apprenticeship strategies to make sure that we absolutely utilise the apprenticeship levy. And there is a provision to actually share that, and we need to be able to share that with our colleagues in primary care and in social care. In line with the ICS People Function Guidance, all ICSs will be expected to build partnerships to develop a much more sustainable and local recruitment route. So this is very much in support of the reports we've heard this morning about how we get local people into employment with our local employers. And that in turn, by creating employment and training opportunities, will start to reduce those health inequalities. So over the next few months, you'll see a range of career campaigns that will be released nationally using the We Are the NHS banner. I personally think that is a little bit divisive. It should be around how we work with our colleagues in social care as well to make sure that it's about a career in health and social care. The plan also proposes that there will be an overhaul of the national recruitment systems and the practices that we use, looking at whether or not we create barriers by putting in place inappropriate entry requirements.
You know what I'm going to say? Okay, carry on, Chris.
Thank you. The plan is very clear on the role of ICSs and builds on the 10 outcomes-based functions of having a one workforce. And members may recall that we presented on this when we did our last update from the People Board. Most urgently, it recommends that ICBs and the wider system partners prioritise the actions to drive recruitment and retention. And the ICBs set out their priorities for workforce action in their joint forward plans. And you will see that the priorities of Cheshire and Merseyside are detailed in our joint forward plan. You'll recall seeing the slide which has got the 5 sales in there which details our priorities. But system level delivery is also dependent on having sufficient capacity and technical capability of workforce planning. And we've previously heard at this board some of the challenges that we face with doing accurate and robust workforce planning at every level, including colleagues in primary care. And so workforce planning training will be critical when such plans start to influence our commissioning decisions. And the plan is clear that over time, ICBs will take responsibility for commissioning some of those training posts, and therefore our workforce plans need to be robust. The plan is very detailed and challenging, but I think it is really important to say we are not starting from a 0 point. I just wanted to share with you some of the work that's taken place over the past few weeks since the report was published to support our delivery of this plan. So in partnership with all my Chief People Officer and HR Director colleagues, we've undertaken a significant data collection exercise which looks at, across the whole of Cheshire and Merseyside, our time to hire data. So we're looking to see whether or not there are any barriers in terms of our processes. We've also done an analysis of workforce planning skills, capacity and capability in each of our providers. We've looked at what recruitment systems are in place, and we've asked organisations to rank the effectiveness of those schemes. We've looked at rostering schemes, what exists in organisations, and how much flexibility there is for staff to request flexible working patterns that will enable them to manage both complex personal lives and also be a valuable member of our staff. We've looked at how much of our apprenticeship levy we've actually used across Cheshire and Mersey since the inception of the apprenticeship levy back in 2017, right up to last year. And we've also got details now in terms of what apprenticeship programmes have been offered by each of our now 16 provider organisations. We've done some benchmarking around capacity and capability in the HR functions, and we've also looked at issues like turnover. And at our HR Director meeting yesterday, we fed back the data that we've received so far on that. And we've got a workshop agreed for all of our Cheshire and Mersey Chief People Officers on the 6th of September to review all of that data and to develop our Cheshire and Mersey workforce plan to support this. But I think it's really important to say we're not going to be doing this in isolation. We will be working with our 2 provider collaboratives. They've both got workforce groups. We've got a Chief Executive workforce lead in both of those provider collaboratives. So the Chief Executive of the Walton Centre will be taking over the workforce lead for CMAST, and Colin Scales will continue as the Chief Exec lead for the Mental Health and Learning Disability Collaborative. We have a very well-established HR Director network, which is really built on many years of good relationships. But it isn't just an issue for workforce directors. It is really important that this is owned by the directors of nursing, by the medical directors, by our colleagues in primary care, and so we will also be going talking to the appropriate forums there. And I'm delighted that we also have a regular slot on our Chief Executives meeting, and we've got the full support of our Chief Executives around addressing the workforce issue. It goes without saying as well that we will work very closely with our trade union colleagues to make sure that this is a robust plan. We also work with chairs and non-executives, and CMAS have one of the chairs of one of the acute trusts who takes a particular interest in terms of workforce, and that gives us the ability to work with our chairs and non-executive directors. Our current governance permits us to use the Cheshire and Mersey People Board to report progress, and that also has membership from our higher education institutes and our further education partners, and we'll bring back our plans into this board on a regular basis. It's not yet clear how this will be monitored through the Regional People Board, but I think it is important that this board absolutely drives and puts its weight behind this agenda. So I'll stop at that point, Chair. It is a very detailed plan, but I'm happy to take any questions.
Thanks, Chris. Chris? And then Adam.
Yeah, thanks, Chris. And if I could just make a couple of points and a couple of questions. So, particularly interested around the international recruitment section, and I'm sure members of the board will support me in agreeing that the international recruitment that's taken place over the last decade has been crucial to ensuring we deliver safe and quality services, and we couldn't manage without them. And I was fortunate enough to be involved in the round of international recruitment in 2014, where the original concept was around, I think the phrase was earn, learn and return. And I was wondering around the support that we could give in how we continue to support our international recruits where they do come across to the UK and they earn, but they learn, but they also take back the learning so that they can share that in a global nursing practice route. And that was my point around that. And also the point you raise around flexibility. And it's pleasing to note that the provider collaborative is working around how we increase flexible working in not just to fit in with a member of staff's working hours, but also about how they flexibly gain skills across a particular area. And the one that springs to mind would be our students of today learn differently than I did as one of the baby boomers. So if you look at cardiac surgery, we have a centre of excellence here around that, but how do we encourage members of staff who want to rotate around our system to gain skills without moving out of the system? And that's it's pleasing to note that the work that the Provider Collaborative is doing, but I'd be interested to see how we can encourage those shared roles throughout the system to gain experience and skills. Thank you.
Thanks. Chris, any quick immediate responses?
Yeah, so we have got a number of work programmes that are looking at, so as Chris said, with the provider collaboratives, but we're also working with social care for things like the trainee nurse associates and how we can provide support from particularly our community trusts to those who've got placements in social care settings. So we've got a huge work programme that will support this, so we can bring back an update on that, but clearly we're working with the directors of nursing, and the directors and deputy directors of nursing did develop a rotational programme, a sort of process and protocol, so we will make sure that that is applied across all roles.
Thank you. Adam?
Yeah, firstly, thank you for the report. I think this is really important. If we're going to shift from episodic care through to a future of support, upstream prevention, and deal with the issues Ian spoke with earlier from the Inequalities and Population Health Plan, then it's absolutely crucial we pay attention to the workforce plan to support that. So thank you. A couple of bits that I just wanted to highlight, I suppose, and some of it you dealt with in your verbal presentation, but the paper was missing a few bits. I'm sure it will be dealt with. The workforce plan pulls out community pharmacy and dentistry particularly, which are those under our auspice, so we really need to focus on those disciplines too. There will be elements, you know, we're not going to be in charge of training pharmacists through university. However, there will be elements of that training that we will need to deal with in terms of providing prescribing training support as they go through their foundation years, and a few other things. And I think we'll need to deal with that supervisory element as well. I bring a bit of experience from some of my colleagues who've had some success with the apprenticeship programme that Health Education England have put in place over the last 3 or 4 years. The feedback's really strong, and we've seen a number of colleagues who've come through the apprentices programme and they've ended up going on to further education through pharmacy professionals to create pharmacy technicians, and that's been really well received by the community pharmacies that have engaged with that. So I'm really supportive of that, and I think that should be good. I do need to figure out a little bit about how the people board links with primary care. And I know you visited the Primary Care Leadership Forum, but I do wonder on the board, is there a primary care voice, or is it someone who works in primary care on a different role? And I need to understand that. But I suppose I've got an offer of help to support if there's anything that can help with in terms of linking with that Primary Care Leadership Forum, you know where I am, and I'm more than happy to offer that.
Thanks, Adam. Claire?
So I might just pick up that last point, Adam, in terms of we do have a primary care workforce group that Dr. Jonathan Griffiths chairs. So I think there's an opportunity to triangulate some of these conversations, and I know Chris and Jonathan have had a number, and I just in terms of the dental, so I think it's really important because it basically comes back to one of the earlier conversations, but I think we probably do have an opportunity, or we might have an opportunity in the future, because we are working with the university and looking at opportunities around developing training opportunities, both in terms of the placements hub and spoke, but also in terms of increasing the number of dental students, and that's one of our sort of key priorities probably over the next couple of years. Graham's already been down, I think, to Birmingham to look at a dental school there, and there was a visit to Bristol earlier this week. So we are trying to link with the universities, building on Rowan's point in terms of those relationships, that we can do stuff for the future. It was just to say, Chris, I know you gave a bit of an update at Finance Committee, and I think it's really welcome this, particularly around the apprentices and making the best of our apprenticeship levies across all of these system partners. And just last point, in terms of workforce is one of the HCP's key priorities, so I think your point in terms of it might be very NHS, but how do we as a system and I know we will through the work you're leading, sort of widen the scope and the specification for this and bring it into the sort of the care development as well. Thank you.
Thanks, good points for Chris to absorb and lead on. Rowan and then Anne.
Thank you. So I've already sat with all of our medical directors from our providers, with our colleagues at Health Education England, to signal our absolute support for training more doctors to provide the care in our region. We've also had that conversation with our universities as well to clearly signal the support for providing placements. But with that, we are demanding, and I've sent this up to the National Medical Director, the resources for us to deliver that high quality education. The time for clinicians to dedicate to their students and the facilities that are demanded to go with that. Our patients deserve the very best doctor, best trained doctor in front of them every day, and our doctors deserve the very best training in order to discharge those responsibilities. It is hugely pleasing to see, and this links into some of our conversations about inequalities already, that one of our higher education institutions, Edge Hill University, where I'm privileged to teach their medical students, actively recruits from the locality those students that might have struggled to reach the 3As demanded because of the backgrounds they come from and a lack of opportunity. Those youngsters get an additional foundation year's training before embarking upon their medical student studies, and particular support from our colleagues at Mersey and West Lancashire to train these doctors from their community for their communities. So I expect Cheshire and Merseyside to continue to lead the way, but also to seek all the resource to deliver the best training possible for our doctors. Thank you.
Thanks, Rowan. Anne?
We've also spoken to the chief execs and they're all lined up as well, Rowan, so that's good. I commend Chris's proposal around that benchmarking stuff, because that use of the apprenticeship levy, for example, if there's someone doing something really clever with that, we all need to copy it, that's for sure, because it is really disappointing that at times we're not able to use all of it, and then obviously it's clawed back, isn't it, into other coffers that we don't get any use of. So, but the point I wanted to make was this issue of flexible working is a really big one, isn't it, in terms particularly of retention, but also in terms of recruitment. It's generally, my trust does very well in staff surveys, and the only question that we weren't like in the top decile nationally for was flexible working. So, there are obviously issues with back office things and working from home and all that, although we do an awful lot of that. But, it's really hard when you're doing, you've got staff shortages, you've got a 24/7 service, and you've got a degree of demand that outstrips anything which could be normally accommodated. So to be able to be really flexible with your staff when you've got all that going on as well is a really difficult one. So I've actually asked somebody, one of my staff, to go to the 5 DGHs who've got A&Es and all the things that we have with the 24/7 service we provide, and find out what the 5 best DGHs do that we all need to copy off. That gives them the best scores from a clinical point of view, in terms of clinical staff feeling like they're given the opportunity for flexible work, because it's really hard to deliver that to many, all kinds of our different members of staff who don't really want to do nights and stuff like this, and yet we've got to have people there at night. So when we find the answer to that question about what those 5 best trusts in the country do, I will share it with you all.
Thanks, Anne. Hilary?
Thanks. It'd be great to get a collective view of everybody's state of readiness, because there's so many players in this, aren't there? And I suppose there's a question for me about recognising the challenges of our HEI partners as well, and encouraging them to work together. They've got to work together on this. And being linked to a couple of HEIs myself, I know their big concern is their pipeline of future educators as well. So what can we do to get joint posts with our universities, more joint posts, for example? And they've also got concerns about increasing their simulation experiences, education by simulation, virtual reality. That's great for our trainees, expensive for our HEIs. So having that collective view of readiness would be useful, I think, for the ICB to know where to put our efforts. I think secondly, there's something, a caution for me in this, because there's a narrative building about less reliance on internationally trained students. So there's something about making sure our present incumbents and the people we will continue to recruit feel valued and welcome and wanted. I think my third point is around inequalities and our public health workforce, particularly health visitors and school nursing, commissioned differently by local authorities. But if we're going to give children the best start in life, is making sure that they are integral to this plan. And I think my fourth final point is around our future staff will be trained differently, as Chris alluded to. But how do we prepare the current staff we've got to be up to date with, we've already mentioned artificial intelligence, but personalisation is a big thing. So we don't get that culture clash when our future graduates or trained people come into the workplace. Thank you.
Thanks, Hilary. Really, really important comments and points being made, Chris. Can I capture this? I think it's going to be important for us to regularly see progress and update, at least on a quarterly basis. I think in that we need to understand what the role of the ICB is, and as it's formed, what our responsibilities are with respect to the long-term workforce of the NHS. But of course, we are concerned about the whole system. So let's make sure we have that sight at this board, through the People Board, coming on a regular basis. But early on, Chris, we really need to understand what the accountabilities are around this table. People comfortable with that? I think the paper was here for noting. Hugely important topic. Chris, if we could go to Executive Director of Nursing and Care Update Report.
Thank you, Chairman. So the paper focuses on a number of items relating to quality and safety issues, and I just wanted to draw the board's attention to a number of the areas highlighted within the paper. At our last board meeting in June, I think Graham in his report updated us that East Cheshire Trust maternity services were due to recommence as of the 26th of June. I just wanted to provide assurance to the board that following the suspension of interpartum services, the services did recommence as of the 26th of June. With a quality assurance visit was held with a number of partners, and also with NHS England and the chief midwife from the region. We have a planned follow-up visit on the 25th of September to further provide assurance about the quality and safety of the provision of these services. I'm sure people will have read in the local press and seen on the local media that the baby born on the day of opening became a little of a minor celebrity. So I was happy to see that. The second point I wanted to draw the board's attention to was around paediatric audiology services. And again, mentioned within the media around an independent review of paediatric audiology services following a review in NHS Lothian in Scotland, where it was found that some babies were undiagnosed, or there was a delay in diagnosis of hearing impairment. And I think the board needs to note that this relates to specialist hearing tests and not the routine hearing screening tests that we do for a newborn. So following the review in Scotland, NHS England conducted a further audit and looks at all providers of the specialist audiology services. And you'll see within the report, it highlights that Warrington and Halton were providers of this specialist service. And to assess the findings within the audit, the service provision within Warrington, we ceased the specialist screening hearing test there, and we set up an instant response group to establish whether we had any concerns within the service provision throughout the period of time. All families concerned were sent a letter, and I think you'll see within the report of all the diagnostic tests that took place between that period. There was one child that was identified as potentially having low harm, and that individual child has been followed up. So the group is still in place. We're still assessing that. We're working with partners, and I will be able to update further on that at following board meetings. And the final point I wanted to raise was the successful recent completed recruitment process for our named GPs for safeguarding within Cheshire and Merseyside. I think there's been a focus on how we think family, and our GPs now cover both safeguarding for children and our adults, and it provides a unique and powerful lens on practice. So those were the areas that I wanted to draw the board's attention to, and I'm happy to take any questions. Thank you.
Thanks, Chris. Any questions or comments? No. Paper is here for noting. Thank you. Anthony, if we can go to the quality and performance report, please.
Thank you, Chairman. A wide-ranging report as ever, but I'll focus, if I can, initially on urgent emergency care in line with what is obviously recognised as the highest risk in the system, and we've just covered in Bath. In terms of where we are at this point of the year, the two key metrics, as the board will be aware, is around a trajectory to improve A&E for our performance, and most notably improve the ambulance response times for category 2 conditions. In terms of where the system sits against both of those indicators, at the end of June, and indeed I've got the latest position in terms of July, we are above our trajectory for both of those indicators. The third indicator we look at is the length of time patients spend within ED. That has seen a slight change, but it's still stubbornly high. That relates to probably two particular issues. One is about doing the right thing. This is about EDs concentrating very much on turning ambulances around in the fastest time possible, even if that means that the ED becomes quite a heated environment and patients are therefore cared on corridors. It's still the best thing to do in the case of avoiding excessive ambulance response times. But primarily the reason why the EDs is overheated is because of the bed occupancy beyond. That is still very high. Cheshire and Mersey always features very highly in comparison. And whilst we are seeing an improved delivery in terms of the number of patients that reside within hospitals, either over 14 days, 21 days, or even against the banner of non-criteria to reside, that is coming down and is beyond our trajectory. Is ahead of our trajectory. It's still very high. You know, it's still out with the regional and national average, but work continues in that area. We also recognise that it's July. This is July and not December, and whilst we can take some comfort that this is a better July than we were this time last year, we are heading into the start of autumn and winter in a better position than we were. It's still likely to be a very, very challenging winter to come. Now today we are expecting the publication of the NHS winter planning guidance. There's probably 2 or 3 features within that that are of note. One will be the timescales for the submission of the plans. Secondly, there's an indication that there'll be a very clear demarcation of responsibilities as to who is responsible for different elements of the 10-point urgent care plan. So that will distinguish between ICB and providers and other organisations with a very clear remit. And coming back to Hillary's earlier point, there's something about us being ready and self-assessment and states of readiness from each of those organisations against each element of those plan. So we as an ICB are mobilising our efforts for winter planning. You heard from Mark earlier, that's already started at place level, and that will be based upon the board report that you saw last month, which talked about our winter debrief, and the board will be aware that we've already got it scheduled that the winter plan will be brought to board in September. That will be beyond the sign-off date, I suspect, in terms of the submission, so we'll find the appropriate way through the governance to make sure all board members are included within that. I'll just touch on planned if I can. I think it would be remiss not to recognise the challenges that Graham mentioned early on in terms of the impact of industrial action. Cheshire and Mersey is disproportionately impacted in terms of the volume of industrial action that we've faced over the past 9 months. To contextualise that, we have probably cancelled in excess of 65,000 operations and appointments during that period, and as Graham said, that's the ones that we have cancelled. We have proactively not booked into some clinics and theatres knowing that industrial action's taking place, and if you compare that with the overall cancellation of 600,000 for the nation, you can see that we are accounting for 10% of that impact. Despite that, we are ahead of our trajectory for delivering 65 weeks, and we fare very favourably in terms of the recovery of elective activity in comparison with North West International peers. And that was recognised only this week by our regional quarterly assurance meeting that Cheshire and Mersey is doing very well in this field under great strenuous, and a lot of that goes to the credit of the collaborative that really managed this very well, with a great reliance on mutual aid, oversight, etc. So a great deal of credit should be placed there. So I wasn't going to dwell on anything else, conscious of time, Chairman, but absolutely happy to take any questions on any part of the report.
Thanks, Anthony. Questions, comments? Paul?
Thanks, Raj. First of all, to say, I think how pleasing it is to see the improvements around health checks for people with learning disabilities and severe mental illness, so really welcome that. An indicator that we have at local level, which doesn't appear here, I've raised this in the Quality and Performance Committee, is around dementia diagnosis, and I'd have thought that this is something that really we should be seeing what's happening across the sub-region. I think dementia is one of the biggest challenges to the whole system in numbers and resources that are taken up. But I think also the importance of early diagnosis has been highlighted really this week with the announcement about new drug treatment, which, if given early, can be absolutely life-changing for people. So I think the importance of that as a metric would be really helpful, and to get a picture of what's happening. As I said, we get it at a local level, but I don't see it appearing on Cheshire and Merseyside. And to have some comparisons, to look at good practice and see what's happening across the sub-region.
Thanks, Paul. If I could ask Anthony could you take that issue away and debate it and give us a view on that? Thank you. Fiona, did you want to say something on that?
Just very quickly, just for a bit of reassurance that improving the dementia diagnosis rates is a key work stream for our mental health transformation programme, and we've appointed 2 GP clinical leads for mental health for Cheshire and Merseyside who will be specifically looking at this, but we can bring back more detail.
Thanks. So let's answer if and how the board becomes cited on that. I think I've got Neil next.
Yeah, thank you, Anthony. Great to see the delayed discharges is going in the right direction. Still some way to go off a plan. But the question for me is about the significant variation across trusts. Are the trusts that are not doing things internally to assist in the discharge, whether it's prescribing, whether it's a doctor to discharge a patient, do we understand the variation, and are we able to put in support to the trust to help them with good practice?
Yes, so the urgent care improvement programme that we have in place does look at, so it has a number of strands around out of hospital, in hospital and social care improvement. Within that we do see the differences between providers as a barometer of system delivery. So yes, we can see at a granular level of detail some of the processing issues within hospitals which affects pathway 0 outcomes. We can understand some of the barriers to pathway 1 where it's more domiciliary care and up to the high end of residential care. So we understand all that, and we have work streams around each element of it. As part of our tiering, we are also receiving some support from ESIST, some national support bodies, and they are working with us in 2 particular providers at the moment, particularly looking at that processing, that internal hospital issues that's causing some delays in the pathway zeros. So that's cited, and we can fetch that back for more detail at a future point.
The more success we have on this, the bigger help in winter as well.
Absolutely, absolutely.
Thank you. If there are no further questions, thanks Paul, again for noting. Thank you. If we could go to Tony, report of the Chair.
Thank you, Chair. I'll be as brief as I can. Just to take the Board's attention to comments about the maternity report. We received assurances to the monitoring of triage and risk assessment. This has occurred over a number of presentations at the Quality Performance Committee, but pleasing to see the standardisation of processes around triage is an excellent step forward and much welcomed. In the performance report, had been prompted, if we hadn't seen this, requiring additional assurance as to how end-of-life care is being provided. So this was admittedly a gap in our programme of work, so that will be introduced over time to the committee. Final point for me is under 4, escalation to the board. We felt this necessary to continue to report issues of the data coming from East Cheshire Trust about the summary hospital mortality indicator. This has been a very much an iterative process. It's been discussed at a number of Quality and Performance Committee meetings. Rowan's had a number of presentations to us that have greatly improved our understanding of this and has a lot of contact with East Cheshire Trust. We asked for a presentation from East Cheshire Trust and duly received that on the 13th of July. It was certainly gave us more to think about, and there's some considerable ways to go to fully understand the issues there. It's very complex, but we remain very supportive of the Trust, but we do think it's time to make speedier progress on this matter. So I think at a meeting later we'll be hearing more from Rowan about how this may progress. So it's just to put it on record, Chair, to assure the board that we're continuing to focus on East Cheshire's mortality data. Thank you.
Thanks, Tony. So a really important point about East Cheshire and us proceeding to the rapid quality review, and we'll subsequently hear about that. Are there any questions or comments for Tony? Again, for noting, thank you. Go to the finance report. Claire, please.
Yes, thank you. So the report sets out the detail of the month 3 financial position, so the position to the end of June. Following the usual format, just to draw out a couple of things. You'll see that we are currently behind where we had expected to be and planned to be at this point in the year, and across the system we were behind in total by 20.5 million. So we'd expected to have a planned deficit at this point in time of 54 million, but actually the deficit that we've reported for the first quarter is 75 million. So there's 2 things to draw out there. One is, as you can see, we are still forecasting that we will deliver our forecast plan for the year of 51 million deficit, which is the plan that we submitted to NHS England. But the 2 issues, one is the fact that we are behind our plan, but the second is the way that the plan is profiled does put a lot of risk into the back end of the year, because we're 75 million adrift, or 75 million planned deficit now, but by the end of the year we're expecting to have a deficit of 51 million. So that you can see the chart in the report shows the trajectory of improvement that we will need to deliver on in order to hit the focus that we've currently got. We'd always planned to have that level of trajectory, but it does mean that we've planned a significant level of our efficiencies that will impact later on in the year. So I just wanted to draw that to the board's attention. The reasons for the variance in the year-to-date position are across a number of key areas. One is in the ICB's own position, we are seeing significant levels of excess inflation on prescribing and continuing healthcare, together with some pressures on the volumes and complexity of our continuing healthcare packages as well. Within providers, we are seeing a significant, well, not in some cases significant, but we are seeing some additional costs associated with providing safe staffing on strike days, and the impact of industrial action there. And we're also seeing across all organisations, the ICB and all providers, some delays in delivering our efficiency programmes. So we're seeing some variances on our CIPs as well. So single biggest area for us to focus on individually at an organisation level, but also collectively across the system, is how we step up the impact of our cost improvement work and our efficiency work. And we're doing, across the finance director community, we're gathering together everybody's CIP programmes across the system so that we can support one another, we can look for areas of best practice. We're doing the benchmarking across to see whether there are there's data that tells us where our opportunities are we covering all of those off with our cost improvement programmes as they stand at the moment? Are there areas we can accelerate? Are there areas that we can work together to do more and further work on? So that's going on. We're also doing the work, and the Finance Committee met earlier this week and talked about the month 3 position in detail, and they're really keen, as are we, to understand the recurrent financial position and obviously the work that we're doing separately to look at the financial recovery strategy over the next 3 years. So we're coming to an end now of the initial stage of that, which is the financial modelling that tells us where our recurrent position is as we exit this year and go into face the next 3 to 5 years, and what our gap is and what we need to do to address that will be the next phase. So I'll pause there. Oh, the one thing I did want to pull out is some really good data in here around our agency costs. So, and it plays to what what Chris has already said about our recruitment that has been taking place over the last few months. So our agency spend is forecast this year to be 112 million across our whole system, but last year we spent 155 million. So not only is that going to help the financial sustainability of our system, but even more importantly is the fact that that is a result of substantive recruitment, which means that we've got more of our vacancies, more of our staff levels are fully employed substantive members of staff, and there's all sorts of patient benefits associated with that as well. So I just wanted to draw your attention to that. So we've had a 25% reduction based upon our current forecast compared to last year, which I think is really positive.
Thank
and
you,
I'll take
Claire.
questions, thanks.
Thanks, Claire. Questions?
Just make a comment. I mean, just to support Claire on this, there's a lot of great work that's paying dividends now, so well done to everybody. But there are 2 key issues that are being focused on. One is the tactical solution to deliver this year's target. At the same time, the important work is the underlying recurrent position. I think the 3-year recovery plans during September, October time from organisers will be really helpful in informing that. So 2 great pieces of work, and I think they're well on track, aren't they? So thank you.
Thank you, Neil. Any further questions? I think as a comment earlier, we can give me an observation. We are in a similar position in terms of non-recurrent CIPs as we have been in previous years. You've got this review going on. What confidence do you think we should have about that recurrent position becoming stronger into the future? Because it's always been really sticky, hasn't it?
It has, and I'll be able to answer that more confidently when we've got the results of the analysis. So we've collected in from all bar 2 organisations now, the detailed CIP programmes, and we're still in the middle of doing the benchmarking. So you're right, we're not seeing... I think last year we saw a significant improvement on the recurrent delivery compared to the year before. And it is a concern. I'm not seeing it yet in the numbers that we've shifted the dial. Although, I mean, there is some really good work on recurrent CIPs being done in lots of organisations, but I don't think it's consistent, and that it isn't in line with the plans yet. So I'll come back with a more complete answer when we've done the benchmarking, if that's okay.
Thanks. And perhaps I could get your opinion from a CMS perspective. Really, really tricky issue, this, isn't it?
I mean, this is a really difficult subject, isn't it? But I do think, and I've said it to Claire, that I do think there could be, again, one of the things that, as a provider collaborative, we try to focus on is reducing variation and sharing best practice and helping to support people. And that's been really effective. And I do think there are other things we could apply that to, and things like, how do the best places with cost improvement programmes that A, deliver, and B, deliver on time and recurrently, what do they do? So there's a huge opportunity, and I'm sure the finance directors do talk about this, but maybe the chief execs need to talk about it too, around what makes that difference between those who successfully deliver on this in a timely way, because they're no good when they're too late in the year, these things, are they? And what can we learn from each other about what the techniques are to best achieve that kind of delivery. So I do think we could put some time into doing some of that kind of thing, because it is a really hard thing to do. But some places, again, do it better than others, and we need to share how that happens.
Thank you, Anne.
Yeah, I'm just, I mean, there is a lot more we can do on this. And
Claire, could I just pick that up, and perhaps through Graham, let's not wait until it's too late to have that. I'd suggest Chair and Chief Exec conversation with our providers. Perhaps we could be proactive and bring that conversation forward, looking to see how we can share that best practice. That's something you give consideration to.
We've gone into 2 organisations who scored highly on a previous self-assessment that we did. So the 2 organisations in the patch that scored the highest, we've gone into those organisations to gather the information about how they're doing and what they're doing, and we're going to in the process of sharing that. So we've started that, but there's a lot more we can do.
Thanks, Claire. And if we could give some consideration, the chairs and chief execs on behalf, because it's a board issue, it's not just a CFO issue, is it? Okay. Any other? Hilary?
So I noticed the increase in volume and price of continuing healthcare, and it's great that there's a focus on that in place. I'm presuming there's some variation there. But as places are concentrating on this, it's really important that we take a look at community provision, particularly reablement, because we don't have enough reablement, rehabilitation, and also excess length of stays. It can easily tip over into the CHC space. So I would welcome when places are looking at that to also tie that in to the wider services. Thanks.
Thanks, Hilary. So again, the report's here for noting. Thank you, Claire. Neil, if we could go to Audit Committee.
I don't want to say too much, because we met 2 days before the last board meeting and I gave an update. Basically, good audit closure, good audit plan, everything's going well. Dare I say that? So I'll just take any questions.
Thanks, Neil. I will come back to the chair of the Finance Committee. I've skipped that. But on Audit Committee, comprehensive report in the pack. Any questions, comments? Happy to know. Thank you. Erica's not here.
No. She asked me to present.
Okay.
So I'll just say very quickly, the paper in the pack describes some of the decisions and things that the committee reviewed in its June meeting. You can see that in addition to looking at the financial position, financial report, there's lots of activity that the committee do as well around procurement decisions and that sort of thing. But actually that was June, and the committee met 2 days ago as well to talk about the most recent financial position and a number of other things. I think Neil actually has probably covered some of the key committee issues that they drew attention to, which is the recurrent financial position and the recovery plans. So there's probably nothing further to add, but any other members of the committee that met on Tuesday, if there's anything you wanted to add in.
Or any questions from board members on? Thank you. Go to primary care. Claire, I think you're covering that.
Yeah. So it was a busy meeting, a very hot meeting as well, unlike today. So well attended from reps from all of our local representative committees, and a welcome to Naomi for her attendance and contributions. So just pick up a few things. So we received hopefully the draft version of the primary care risk committee with a few more adjustments. We're going to receive the final sort of up-to-date version at the next meeting. We signed off a GP contractor application for practice incorporation. That was supported by all. We signed off a consistent approach to protected learning time across the 9 places, which will sort of commence from September onwards. I think it's important to have that consistent approach, so there's no sort of postcode lottery around that. We received a detailed update on the primary care access recovery plan, but obviously we covered that at board last month, but that's the committee where we'll do all the reporting on that and in terms of the progress, and then we'll have an update every month. We've talked about it in Graham's report, but we signed off the 2023-25 dental improvement plan, and I think that was well received, but it was quite a detailed discussion because I think dental contracting is new to a lot of people around that committee, but having the representative committee members helps on that. And then we also discussed ongoing GP practice contract issues. So thank you.
Thank you. Thank you, Claire. Graham?
So 2 things, if I may, Chair. One on the protected learning time. Can we just make sure that there's a post-agreement engagement with NWAS? So
it's already happened.
It's already happened,
Yep.
Thank you. And then secondly, when we put together our winter plans for this year, we ought to be modelling what-ifs a long time in advance and be really clear about in what circumstance would we enforce a blanket cancellation of protected learning time because of system pressures. So again, can we make sure that that's joined up?
So we have had that discussion, and that was part of the paper. So all the LMCs were party to that discussion before we took it to System Primary Care Committee, that in extremis we would have to cancel another one. But we're not having protected learning times in December and January. That's already been agreed.
Thank you.
Thank you.
We're happy to move on, note that paper. Thank you. And if we could go to the Transformation Committee, Claire?
Yep, thank you, and thank you to Neil. So Neil attended the committee for the first time last month. So we had an update on the digital diagnostic work, which I think there's another paper coming back in September. We had an update on the transformation programme funding for quarters 1 and 2, 23-24, but that also included a review of the underspend from 22-23. So we agreed as a committee that we would return just less than 400,000 to the ICB to support the 23-24 deficit. We discussed the process that we're going through for our 23-24 transformation funding, and there's sort of quite a detailed, rigorous process for that. We also had an update on specialist commissioning, because that currently sits through the Transformation Committee, and our requirement to submit a pre-delegation assessment framework in September. And due to the timescale, one of the asks of board is that the board delegates authority to the Transformation Committee to sign off that PDAF, the assessment framework, so that we can meet the national timeframe submission. There will be another version in the future, but I think we wanted a board to delegate that to Transformation Committee, please. And then Ian has already mentioned, but we, in terms of responsibility for treating tobacco dependency, that sits with the Transformation Committee, and we received a report on progress for that. But we did recognise as a committee that we required greater information in terms of the data and some of the trajectories around that. And Ian and I have a meeting with the regional team next week, so that's an area we need to look at more in the future. Thank you.
Thank you, Claire. Any questions or comments for Claire? If I could go first to the paper for noting, other than the approval that's been sought for the PDAF, again, remind what that... Yeah.
Pre-delegation assessment framework.
Is the board happy to approve that delegation at this time? Yep, thank you. And it's a report for me from the Health and Care Partnership Committee meeting that happened a couple of weeks ago on behalf of Louise Gittins, who's the leader of that committee. Good meeting, some strong conversations about the terms of reference and how our local authorities will engage with that. There's ongoing work which we hope to bring to a conclusion relatively soon. However, that's not getting in the way of progress. It's an important conclusion to reach. The progress is what's important, is our work around understanding what priorities are, and that's articulated in the draft interim strategy for the healthcare partnership, which is all centred around all together further. So it was a good meeting because we got good consensus across all various parts of the system around the direction of travel, to centering on a small number of priorities which will be articulated in our workshop in September. Happy to take any questions on the report. Have we misspelled it? Apologies for that to Councillor Gittings, and we'll make sure that happens. Thanks, Paul. Yep, happy to note. So, closing remarks. Again, really good conversations and discussions around the table today. I thought it was another good meeting. I've not been notified of any other business. No, I'm pretty sure I haven't. And I'll go to close the meeting. So I'll come to it at the end of the meeting. I'll go to close the meeting. Date and time of the next meeting is the 28th of September over in Halliwell Jones Stadium, Warrington. That is when the AGM happens. And speaking specifically to members of the public, do make every effort to get there, and it will be an interactive meeting where directors and board members will be able to engage with more time with members of the public, and we'll have a process of enabling the public to pose some questions prior to the meeting so that we can have that debate and discussion at the AGM. Meeting's closed. Thank you very much.